Vijay Bhaskar on the dais. One of the guest of honor, the member of Legislative Assembly, Dabolim. We are into the Goa's Dabolim village. The Dabolim constituency MLA, Mr. Movin Godino, has just arrived with us. We extend warm welcome to MLA sir, Mr. Movin Godino. I request Dr. Venkatraman sir to escort Godino sir on the dais. Chairperson of CSEPI, Dr. Sanjay Deshpande, is already on the dais, and Vice Chairperson, Dr. Goda Venkatraman, is also on the dais. May I request our Secretary, CSEPI, Dr. Padmini Prasad, to come on the dais. May I request Leena Malde to escort Dr. Raj Brahmbhatt, our founder trustee, on the dais. And also, may I request Ms. Fancy Malde. May I request Dr. Amit Mutha to escort our workshop leader, Dr. Prakash Kohari. So friends, on behalf of organizing committee of National Conclave of Sexology, Goa 22, I welcome all our delegates, associate delegates to this conference. Council for Sex Education and Parenthood International, CSEPI, has become 41 years old. It is the only association which holds the scientific conference at least once in a year in last 41 years without any break. This is one of the marvelous achievement for any academic organizations, I believe. Though it amounts to the self-patting of our back, but nevertheless, it is a perfect, valid gesture. Sex was and is still considered a taboo for many people, and they are not comfortable using the word sex. Sexual medicine is not a recognized faculty of medicine. Hardly any university is offering a degree or certificate or diploma course. As a result, sexology was restricted so far to the Khandani Shafakhanas and Dawakhanas, and they have flourished because doctors were not in a position to offer any effective remedies. CSEPI was born as a result to tackle this scenario. Currently, India is at crossroads. as far as sexual medicine and sexuality is concerned. We are uncomfortable as a general population. We are uncomfortable with sexuality education, but we are the second largest population on this earth, where sex-related crimes are also in a huge number. In media, TV channels, and particularly OTT platforms, there is an explosion of sex, nudity, and vulgarity. And we are still seeing lots of unconsummated marriages where people are not able to do the natural copulation process also. We are increasing the marriage age for girls and boys, but we are not teaching them how to handle their sexual impulses, which they develop by the age of 12 years or 13 years onwards. On one side, we have medical tourism flourishing for cardiac facilities, joint replacements, the dental treatments, the ophthalmic treatments, cancer management. But as far as sexual medicine is concerned, you can find on fingertips the Department of Sexual Medicine, exclusive Department of Sexual Medicine in the government colleges. So this conclave and pre-conclave workshop, which was very well appreciated by delegates yesterday about the workshop I'm talking, it's a small effort to enhance the medical practitioners' knowledge in sexual medicine and enhance their clinical skills. The theme of this conclave is bridging the gaps in sexual health. The medical science is now heading towards more and more compartmentalization from specialty to super specialty. So we are treating only the organs and not the person behind the organ. So this is a small gesture to bridge the gap in sexual health. At an exotic place, Goa, which is internationally known and a crown of Indian tourism, we will serve both the purpose of knowledge and fun as well. This conclave got postponed more than twice due to corona pandemic. Everyone knows that. Finally, with all our CSEPI family support, and it became a reality despite some obstacles coming in between, and we have received a good support in physical as well as online. Many academic partners have joined this event, like IMA of Goa State and some of the districts like Tiswadi, the Panji Obstetric Gynec Society, the IMA of all neighboring districts of Maharashtra like Sindhudurg, Kolhapur, Sangli, even Belgaum, KLE Institute of Higher Medical Education has also joined us as an academic partner. And not to forget the Vision Hospital from when our MAPSA, Goa. And we have received good support from our pharma friends to make it a reality. I wish this workshop and conclave would be totally utilitarian for all and memorable to you for a long period. We have made tireless efforts to give more than 100% to all the delegates. Still, if you find some shortcomings, I beg your pardon and I request you to pardon the organization committee with a large heart. Bhul chuk lena dena, that's what we say. Thank you. Once again, welcoming you all. I request Dr. Sanjay Deshpande to give presidential address now.
Good morning. Thank you, Dr. Shirish. At the outset, I can definitely tell you, it was the energy and enthusiasm of Dr. Shirish Malde, which is the sole reason for this conference today. So I think we should give him standing applause. Thank you, Shirish.
I am overwhelmed and no words can express this gratitude. I only wish this remaining 1.5 days of our scientific sessions would be really useful to you all and you enjoy the go on hospitality at this exotic place.
Yes,
Thank you.
yes. So now I will start my formal address. Honorable Chief Guest and Guest of Honor, our first man, Padma Shri Dr. Prakash Kohari sir, our you can say founder trustee, Dr. Brahmabhat sir, Dr. Padmini, our honorary secretary, Dr. Venkat, my elder brother, though he is vice chairman, but he is my elder brother, and Dr. Shirish, and all the dignitaries and members of Council of Sex Education, Parenthood International. I welcome you all for this very important conference. As rightly told by Dr. Shirish Malde, that Council of Sex Education and Parenthood International is the only organization founded in 1980-82 is taking the conferences every year on sexual medicine. We have more than 800 members and fellows in our organization. And perhaps we must be the largest association of sexology in whole world, not only in India. Now, fortunately, there are many other organizations also, and we welcome those organizations also. Because being a person from Indian Medical Association, as it was only one organization when we started after independence, but later on, we had many super specialty organizations. So we have to be democratic. We have to be democratic and we have to allow all other organizations also to flourish. But this is a mother organization, if you say sexual medicine in India, founded by late Dr. Mahindra Vatsa. And in fact, he is the person who has trained most of us. Means I distinctly remember in 1997 when I joined CSEPI, at that time he was so generous to help me in coming to Chennai and then attending the conference. So we cannot forget Dr. Vatsa whenever the word CSEPI comes to us. Same thing about Dr. Prabhu, Dr. Reddy, Dr. J.V. Bhatt, my predecessor as chairpersons of this august organization. These are very big names. I am not that big. But being an organizational man, I am handling out these responsibilities of chairperson of CSEPI. As you know, sexual medicine is the most neglected topic in medical sciences. As rightly told by Dr. Shirish Malde, that there is no formal degree of sexual medicine. Some of the deemed universities have started their courses about sexual medicine. But sexual medicine, sex education, counseling and therapy, the whole umbrella of topics are not dealt by any official academic course in India till now. Same is true with many other Western countries also. We don't have official degrees about sexology. I always say that as a general person or general man or a woman, general citizen of any city or any country, I know who is the cardiologist, I know who is a neurologist, I know who is a psychiatrist, who is a gynecologist, and name any specialty. But being a common man, I never know who is practicing sexology. There are many quacks operating in this field, but CSEPI is the only organization where we are giving trainings through our conferences and workshops to all these fellows who are very much interested in the field of human sexuality. And that is the big work which is being done by CSEPI. With us, there are many other partner organizations like Indian Andropause Society. The chairman is Dr. Venkatramana. Then Men's Health Society of India, and as well as Andrology India. These three organizations, they are always with us as academic partners. So I welcome all the office bearers of these organizations also. I limit myself to welcome address only. So welcome you all the chairpersons, all the delegates, and most importantly, all the speakers. Welcome to the press. Welcome you all. Thank you very much.
Now we proceeding ahead. I request Dr. Raj Brahmbhatt to welcome our chief guest, Surgeon Commander, Surgeon Captain Vijay Bhaskar. Sorry for a little confusion because in Navy, the vocabulary and the ranks are not so commonly known to us, whereas armies we are very well versed with. I'm extremely sorry. Surgeon Captain S. Vijay Bhaskar will be felicitated by Dr. Rajshekhar Brahmbhatt.
Before I hand over, you were not knowing I'm a B-Cert certified naval cadet.
Okay.
I was on Vikrant for 1 day. So I am really very, very happy. And at Oceanic, I had conducted a whole day workshop for the psychiatric. It's my great pleasure. Thank you, sir.
Now I request our Dr. Prakash Kohari to felicitate our guest of honor, Mr. Movin Godino.
It is a great pleasure to invite you here, sir, and all the honor for the spending time here. And we really feel very, very happy.
Taking the program further, today we are missing our emeritus chairperson, Dr. D. Narayan Reddy, very much. Due to his ill health, he couldn't attend this conference. First time in his life, he has missed the CSEPI conference. He is also regretting it very badly, but his health was not permitting to travel from Chennai to Goa alone. So he has been a extremely good teacher, we all know. So he has written a book, and today we have a privilege to release it from the dais. So I request Dr. Prakash Kohari sir to release the book, which is authored by none other than Dr. Narayan Reddy. And I request Dr. Venkat Raman to say a few words about the book, the making of the book. Dr. Venkat Raman, sir. Yes, sir.
We all know that sex education is one of the schools that causes subject to psychology and physiology of sex and sex dysfunction are not of and the majority of the psychiatric residents are dropping negative. Friends, resulted whenever a client or a patient approaches a physician, what was due, either because it was rank prescribed one of the evidence using the total of the drug or drugs or the so-called tectonics, which have been they are effective only by the well-known mechanism of suggestion or withdrawal. The book of Dr. Narayan Reddy, I'm sure, will help this exploitation to a big extent. I wish you all of us. All of us.
My friends, Padma Shri, Dr. Prakash Kohari ji and Dr. Narayan Reddy, both are very good friends. These are the two pioneers who took sexology from India to the worldwide. They brought not only from the bedroom to hall, from hall to conference, from conference to international. These are the two figures they have taken it there. And this book written by Dr. Narayan Reddy, I have gone through, I have given my opinion also to Narayan Reddy. Very, very useful for the newly married couple. All of you can recommend this as a book instead of giving some money in the marriage, taking some costly presentations. We can present this book. Very, very useful for the newly married couple. For all the delegates, this book is freely available at Himrais Pharma. Once you visit that stall, you can get this. And I thank Himrais Pharma for publishing this book, generously giving funds for this, and a great achievement. I wish God wish them, and I wish you best of luck. Thank you.
Delegates would like to know from Himros Pharma, there are many aspirant authors from this crowd, whether they will be supported by Himros Pharma or not. Thank you, Hemant sir. Now, another moment to appreciate and recognize the contributions of our stalwarts. And organizing committee is greatly delighted to honor our three stalwarts who have, just like Venkatraman sir said, the sex was brought from bedroom to the hall and hall to the common platform in the public. And today, if the sex is being discussed openly, it's all because of the great efforts by these three stalwarts. To begin with, the first name I'm very happy to share is Dr. Prakash Kohari. Internationally renowned sexologist who has been awarded several awards, including the highest award of many global authorities and many global associations of sexual medicine. I won't name each of them because then the talk will go very long. Dr. Prakash Kohari was conferred Padma Shri, the fourth largest civilian award in India by the Honorable President of India, almost 20 years back, sir, more than 2 decades. And we all know that he has carved and paved a path for all of us. If we are walking very comfortably on this path, it's all the groundwork and the basic work done by Dr. Prakash Kohari. I would say Padma Shri Dr. Prakash Kohari, who have an honor of starting the first Department of Sexual Medicine in any government hospital. It was SET GS Medical College and KEM Hospital in Mumbai, for which for more than 3 decades he served as a head of the department and handled more than 55,000 cases on record. So I request Fancy to bring the memento, and I request our chief guest, Surgeon Captain Vijay Bhaskar, to confer this award, Icon of Indian Sexology, to Padma Shri Dr. Prakash Kohari sir. Second person, we just spoke about him, his efforts to make the young couple comfortable with each other. Because see, we know that there are so many workshops, training programs, and grooming programs for any job in the world, you say. But are there any training program for the man and women to be husband and wife? No. Such books make the sense. So none other than Dr. Prakash Kohari, Dr. Dega Narayan Reddy is also, we take a great pleasure to honor him also, the icon of Indian Sexology Award. Since he is not present, I request Dr. Goda Venkatraman to accept this. And I request MLA Sir Movin Godino Sir to hand over this token of love and gesture for Dr.
Humbly on behalf of Dr. Narayan Reddy.
And finally, one cannot forget the third icon, our founder trustee, who has held the fort of our sexology very brilliantly, and now is serving very brilliantly as our emeritus editor also, Dr. Rajshekhar Brahmabhat. We are really proud to appreciate your achievements and your contributions to the field of sexual medicine in India. And I request both of our chief guest and guest of honor to confer this token of appreciation to Dr. Brahmbhatt sir. So after this appreciation, we continue to do so for our beloved colleagues and friends and our mentor, of course, who left us in this last 2 years. So I request Dr. Raj Brahmbhatt to have a small session, very, very small session, I would say, in remembrance of our four persons who left us in this last 4 years.
Vivek, can I have?
Request all the people on dais to, stand for a couple of minutes. The screen.
I'll be very short, Can I have the pointer? Friends, as Shirish has said, if I have to talk about this 4 family members who has left us in last Corona period, I think it will take a half a session. I was fortunate to be close to all of them. And today what I'll say is in a bullet point or a shorthand. So as early as Shirish Bhai has said, I'll try to cover it. It is not only tribute to Dr. Vatsa, but Dr. Esther Dubey, Dr. Saroj Gumaste, and Dr. Parag Patil. And this is not Dr. Raj Brahmbhatt, but I am doing on behalf of all of you CSEPI family members. Dr. Vatsa was born in Myanmar. His father was an army doctor. And then he moved to Calcutta, Ludhiana, and many other places. At last, he landed up in Bombay, and at JJ Medical College, he completed his studies. He was a football player. Then he joined to Nair, Vadia, and many other hospitals. He got married to Madam Pramila. If you have seen old movies, or old Gandhiji's film, you will see a Chicago radio. She is a daughter of a Chicago radio, Pramila, and they had a wonderful marriage life. They have only one son, known Gautam, and they had a wonderful marriage life. This is their whole family, along with daughter and granddaughter. Then he started working. He had many hats on his head, and every time I asked to talk to him, I used to say, that's another story. In one life, he has done varieties of things. And I feel that even if I do 1% of what he has done, then the life will be worth. He joined Glaxo company, and that organization helped him in many ways in the life. And the most important part, he joined Family Planning Association of India. Dr. Avabai Vadia, who was Padma Vibhushan. And I was lucky to work with her for 15 years. She was a legend. First time in 1976, with the International Planned Parenthood Federation of London, they organized a workshop in Pune of 3 days. And after that workshop, immediately Dr. Vatsa took up SECRT, that is Sexuality, Education, Counsel, Research, Therapy and Training. And as I said, I was trained under him and he was like my father. So after when he gave the whole thing STCR to me. There were 44 branches in India, right from Manipur to Kanyakumari, Rajkot to the other side, Kashmir and other places. So this is what was at the heart of it. He received many awards, including the World Association of Sexology. They gave him Man of the Year. SCCRT, as I said, he trained up thousands of counselors all around India. I had moved with him to the remotest places like Bhubaneswar. So we had gone to Kalakhandi area and in Gujarat and Karnataka and every places. And right from the slums area to a doctors, to a consultant and to a family people. We have gone and trained so many people. That was his one-man army and he gave that legend to me. These are the two giants over here. SCCRT, after that CSEPI, last 40 years, we have been working together. And the whole idea was Sabka Saath, Sabka Vikas. Everybody was brought under one umbrella and that work Dr. Vatsa has done. And he had a knack of getting foreigners. I tell you, he got the John Money, John Bancroft, Douglas Hooper, June Reynish, Barry McCarthy, and many others. And with his word, people used to come. He used to make them comfortable at the home. And not only in Bombay, Chennai, Delhi, he used to conduct workshop and spread the excellent knowledge which was available outside. He has been a great speaker, orator. And that's what he trained me. He will take me to Rajkot and say, suddenly Raj, you will go and speak. And you'll be surprised that this is how he said you should be prepared like a cricketer, that any ball comes, you start playing and hit sixers. So all credit goes to him. You can see the stalwarts, Dr. Narayan Reddy and Venkat Raman. Venkat Raman has been doing wonderful work and I'll show you a picture within a minute. This is World President Wiley. And that was the funniest incident. I cannot stop talking to you for a minute and Dr. Nath is here. Wiley is a world president. He came. Dr. Vatsa said, go Raj, take him, show him the Bombay. He came in the morning. I'm a pure vegetarian. And when I took him, I was worried where to take him for a lunch. He said, Thali khana hai. I was very happy. We took him to the Samrat. Then in the evening, Dr. Prabhu, Dr. Narayan Reddy and Dr. Vatsa, they said, we will have a Wellington Club dinner and wine and drinks. Me and Wiley went there. And then there was a bombshell. Wiley, morning he came, so he was in a half shorts. And Wellington Club said, we will not allow you. So Dr. Vatsa called me, Raj, you use your charm. So I had to do nothing. I went to the manager. I said, sir, one thing which you can help me, and I need your help. He said, what can I help you? I said, no, even the Prime Minister cannot do, but you can do right now here. He said, what? I said, I want one trouser. And he started, from where to get? I said, these all waiters are there, give me one trouser. And believe me, while he went to the gents' room, removing his half pant and everything and then came back. This is how Dr. Vatsa used to train me. I think जोर से ताली बजा दीजिए. Another Dr. Prabhu, Dr. Narayan Reddy, and from Alwar, our friend, Saroj. We lost her. In 1 minute, I'll tell about her. These are all the conferences. And as I said, SCCRT he made, he gave it to me. Flash he made, he gave it to me. Medical advisory panel, he gave it to me because I was in Bombay. So I was closest to him. This is how our friend Dr. Venkatraman used to do. I think he needs a big clap. Every year he has been coming and felicitating all of us. And this is how our family goes on growing. And lastly, this is our secretary, Madam Padmini. The second one who is sitting over there is Madam Dubey. She died very recently and we never knew what happened to her. She was one of the founder member. Dr. Vatsa took me for the first ever workshop of sex in Sri Lanka in 1991. And after that, Sri Lanka sexual medicine started and people started working in the field of sex. He had been always calling me at home, taking a cup of tea, looking at the ceiling. Was a wonderful time with him. And the last one, I cannot think about it. When I heard he was ailing in a Beach Candy hospital, his daughter-in-law Deepa was there. His sister had come. He was unconscious, fighting between life and death. And when I went, suddenly he opened his eyes and he said, how are you? How is CSEPI? This is the word. Even at that moment, Dr. Vatsa thought, I think no one can think in such a illness and other things more than CSEPI. So I pray to God, wherever you are, we are always with you. Whatever is good in me is yours, sir. And I say, not only me, but all the family members of CSEPI, I promise you that we all give promise today, we will see that CSEPI will continue for 100 years. That is my wish. And I request all of you to join with me. Now, these are the founder trustees, Patricia Sheeler, Dr. Vatsa, they are no more, Dr. Prabhu, no more, Dr. R.S. Dastur, great writer, C.L. Javeri, Saroj Mukhi, and last one was Esther Dubey. So when he was ill, he said, Raj, you will have to now speak out. I said, when you were there, I never spoke. We respect and we give a great tribute to him. Next is Madam Esther Dubey, who was our founder member. She used to work exclusively for the mentally challenged children. She had an institute at Tarap, and her husband, Vijay was a great person in HMV music, and her brother Ruben was a biographer of Raj Kapoor. And she has been a great counselor. She has written a manual how to manage the mentally retarded children and their families. Saroj Gumaste, we lost her last. The best part, one line, she has worked in a Bhaskar area and Gotul Pratha, what is happening, and reproductive systems. She has done many work. She was a founder person of the medical center which has gone all over the world. And the best part, she was very much interested in literature. Last 3 months, she fought against the death and ultimately she succumbed to it. So friends, these are the people. And lastly, video for 1 minute. The youngest friend of mine, Dr. Parag Patil. When I received an oration award at Solapur, one night he was with me, Dr. Parag Patil. Vivek bhai, can you start the video? It is made by his friend from Dombivali. Vivek. It's a 1.5 minute video.
Dr. Parag Patil, an irreplaceable part of the Kalyan medical community, was a multifaceted and heartfelt individual whose presence was felt at every social and medical related event. He was one of the finest and the most skilled gynecologists in Kalyan city. His surgical skills have helped thousands of patients, not only his own, but patients of his fellow colleagues in the gynac community as well. Dr. Parag was a brilliant, well-respected doctor, a good orator, an excellent communicator, an academician par excellence, and to top it all, a multilingual, versatile singer. He had a childlike enthusiasm for every occasion. His smile and enthusiasm was so infectious that his mere presence could de-stress any situation. Dr. Parag's life was abruptly cut short, but he was able to achieve great success in almost every field and aspect he was involved in. He interacted with so many people in so many different ways and touched so many lives that everyone has an anecdote or memory of him. Dr. Parag, thank you for inspiring many. We will always miss you.
He was a true COVID worker and warrior. He was in the fever ward as a volunteer. I called him up, Parag, where are you? He said, I am here in the fever ward. I said, please take care of yourself. By evening, he was breathless. 4 days he was in Dombivali, 4 days in Jupiter at Thane, and 8 days in Jaslok Hospital, and he left us. I tell you, he was the bridge between Foxy and whatever Foxy, that is Gynec Association, is because of CSEPI is there. I would request all of you, you have lost really 4 pillars. And it's not only my personal loss, but I say it is a loss of CSEPI. I'll request you to stand up and have 1 minute silence in the memory of them. Thank you. Om Shanti Om.
Thank you, Dr. Brahmbhatt. It's our custom that we remember all our departed souls. I request all our dignitaries to come back to their positions on the dais so that we can move ahead. Dr. Prakash Kohari is leaving. Thank you, sir, for being here. Now I request, and before that I will introduce our most senior MLA from this present constituency in which this conference is being held. This is Dabolim constituency of Goa. Mr. Movin Godino is the longest serving MLA for 7th consecutive time. He has been elected with a huge margin, and in previous governments he has served very important portfolios like power, industry, transport and panchayat. In the very current ministry which just finished 5 years, he was into transport and panchayat, right, sir? He is considered to be the GST tiger. It is said that if the most complicated and ununderstandable phenomenon is there, it is the goods and service tax, GST. Most people who are into the business would understand the intricacies of it. And I'm very happy to and delighted to say that Mr. Godino sir had a very, very important role in the GST Council of India. You can imagine the leading and winning the 7 consecutive polls in a constituency is not a small job. One has to work tirelessly 365 days, 24/7 towards the population and the people and their issues. And today, if you see the Goa, one of the state with a good happiness index, I would say the Dabolim constituency would be the top in the happiness. Incidentally, we had another guest of honor, MLA Dr. Chandrakant Shetty, who happens to be our academic partner through Vision Hospital, is very much preoccupied. So he has promised us to come in the evening program, and he will be a part of us in the evening. And despite having a very, very busy schedule, and he has rescheduled his timings, he has, his previous commitments, he rescheduled, and with our request, he has come and joined with us. So we are very thankful from the bottom of our heart. Sir, thank you very much to grace the occasion. And in the next government, which is likely to be formed in a week's time, we wish that you again hold a very, very important portfolio for the state and lead this state in a very progressive state. So we request you to say a couple of words. You can give.
Organizing Chairman, Dr. Shirish Malde, Dr. Venkat Raman, Dr. Prakash Kohari, Padma Shri had just left us though, but we did have a good interaction on stage. Surgeon Captain Vijay Bhaskar ji, Dr. Sanjay Deshpande, Dr. Raj Brahmbhakt, Dr. Padmini Prasad, all the other doctors present here, ladies and gentlemen, I'm very happy to be with you this morning to participate in a sexology first, I think, a national conference being held here down in Goa. In fact, for some time, I was thinking, why me for this conference? But as I am amidst you, I was just thinking, why not me? I want to say one thing. I always believe that India is such a great country. We have developed every facet of society, whether it is in medicine, whether it is in science, whether it is in engineering, whether it is in space. And one area, as rightly said by various speakers here, and which is very much a necessary part of our lives, it's still taboo to discuss about sex. I really don't understand why there is a little bit of inertia to move forward. And that's the reason I would first compliment your organization for moving forward in spite of really not getting the traction with the people what you all should have got, and the encouragement with dedication, with hard work, with perseverance, as a very integral part of life itself, you have come this far. Relentlessly working in educating people on sex. Parenthood International, as you all say, parents have a very important part to play as far as educating their young children is concerned. But I really don't understand why it does not come out openly as a subject, in a manner where we discuss it openly, grapple with the problem, and if you have to tackle any problem, it is said you have to hold the bull by its horn. There are so many problems. What ultimately happens? People go to quacks, people go to people who are not qualified. And when we have such renowned doctors, like for example, whom I know and I have read about Dr. Kohari, why has it not been developed as a separate subject in various universities as a curriculum? Why can it not be carried at the lower level in high schools, in schools itself? Today, gone are the days when we said that young children never understood anything. In fact, you get to hear stories, you get to hear incidents which we feel very sad about. And this happens because we are not ready to discuss it in open. We are not ready to get it on the table in a manner where scientifically we can work out solutions. You are doing your bit, but I need, so people in society need to do even more in tandem with your efforts. Unless you involve other policymakers, unless you involve even, for that matter, elected representatives, whether in the councils, whether in the panchayats, whether thereafter at lower levels in the schools, at social organization, it's only then that we will really able to scientifically evolve a system where people are not unhealthy. I always say, two things are necessary in life if you have to keep fit. You have to maintain a healthy body and a healthy mind. Be a good citizen with wholesome thoughts in your mind, with very positive thinking. When will this happen? I say two things are necessary. One is the exercise, and if you have good exercise with a healthy diet, you also have to have good exercise. Many a times people, they just look at me sheepishly. Why feel shy? Is it not something, a need that is necessary for a human? Just like you need food, you need sex as well. And I would also choose to define sex a little differently. Anything that gives you extreme pleasure also has to be classified as sex. It's not only the physical sex. It's only then when you stretch this definition a little further, perhaps you'll be able to get something more on the table, people talking more freely, expressing their thoughts, helping you to understand them deeply. And then many solutions will emerge. We need not feel shy. First of all, in our homes itself, it is high time we openly chat with our children. Forget about chatting about sex. How much each one of us, let us ask how busy we are in our life. Do we chat even the normal things? Do we have time for our children? Do we give them quality time? Let us ask ourselves. And where is it we will discuss about sex? That is going to be getting the least priority. And therefore, problems from, as they say, you can build a mountain or you make a mountain out of a molehill. The thoughts, negative impressions, everything keeps on building negatively. You have to see it at the root. It's only when you see it at the root that you will be able to identify things. And I want to say one thing. We have got so many sciences. In fact, if you look at any major scientific temper which is being promoted now, unless somebody in the West really compliments you, does something exceptional, you are not applauded. People don't recognize. This is what is our fate as Indians. We fail to realize how good we are. We fail to look inwards towards ourselves. How much we have achieved, what achievers we are. It's only when somebody abroad recognizes in the Western world something happens, we think, oh, we are great. We got it in us, inborn in us. We Indians are born great. You'll go little bit to ancient times. Whether your best of doctors find out when surgery was actually performed, much earlier times than what is recorded now, where the Westerners claim. Similarly, a land of Kama Sutra. That's why I get amazed. How do we feel shy? See pictorially how well it is depicted. See in terms of bronze work, stone work on different walls adorned in important places. Right from yesteryears, the olden times, it was there. And here we are in modern times, we say we are modern citizens and we are feeling shy. It's time we come out of the closet. And I'm sure Goa is a place which propels minds, comes out with something exceptional. This is the place. We use a very small portion of our matter in our brain. If it goes a percentage higher, you can achieve a lot. You can get more things where you will dwell upon and come with something which will be practical, which will be good for society, good for understanding and promoting healthy sex, which will lead to a healthy society, reduce crimes, help you evolve solutions, and all that is necessary in that direction. Goa is one such place. I'm happy all of you have chosen Goa to have this conference. I'm sure many meaningful discussions will happen between you all. There'll be the best meeting of minds, assimilation of the knowledge you have acquired, the experience what you people have had. And once you put it all together, I'm sure you will always remember your Goa conference in terms of doing something really nice, which will make you to be remembered, not only amongst your colleagues, which will send a message across chapters in various parts of India, as well as your friends abroad. And that is what I expect the high level of deliberations to happen in my beautiful state of Goa and in my beautiful constituency called Dabolim, in this beautiful hotel of Bogmalo Beach Resort. And I'm sure that you will take this seriously, and I'll have occasions to note this. Even the book, I was just glancing through the book written by Dr. Reddy, a good contribution, I must say, worthwhile contribution. Such publications are necessary. You need to make short films as well about sexual subjects for the young people, so that they don't go wayward. They don't understand it from their friends in a very dirty manner, going the crooked way. They should know what is what, so that their young minds are able to decide. One ultimately has to realize your body is a temple. You have to protect it. You have to look after it well. A very integral part is the sexual system in the whole biological machine, the most wonderful machine in the world given by God. You look at various inventions that come, everything through a sensor. Today you have robot, but have you realized that the most wonderful machine in this earth of ours, in this world, is we the humans? What a wonderful gift God has given us. So it is for us to preserve and protect and do all those healthy things which will protect your mind, which will, I should say, help you feel better, have a happy quotient in life. Ultimately, what is it that any government also inspires? To improve the quality of life of its citizens, to make them healthy and strong, to make them wholesome citizens with traction towards the elected government, so that you produce and you march forward in a situation where all are the winners. So this is what is necessary. I wish you all the best at your conference in Goa, because I think all of you are, I would say, pioneers in your respective field as doctors, giving service to society. It's a noble profession. And I hope you realizing that at this very conference, some huge, noble and good things happening. That will be the order of the day. Once again, I thank you for having specially invited me. I'm happy I am in your esteemed company, and I'm sure there will be more times when perhaps we can meet on other occasions. Thank you very much indeed. All the best.
Thank you very much, Godino sir, for your thought-provoking speech. It was one of the wonderful piece of talk, one could say. Not just the politician's tall claim, but you touched the really hearts and mind of our delegates, sir. Thank you very much for sparing time from your really very busy schedule And thank you very much, sir. Now, I am honored to introduce our chief guest, Surgeon Captain S. Vijay Bhaskar. I would say one secret, since a few years I was claiming for Goa conference, and in Goa conference, I said ki wherever, if I am getting a chance from our CSEPI executive body and our AGM body, if I get an opportunity to hold a conference, my chief guest would be a person from defense. Because defense forces are the one because of which we are very much peaceful within the country. They are at the borders, and particularly Navy are in the mid of the seas for many months together. Their sacrifices, no one can fathom. So it's my great pleasure to introduce Surgeon Captain S. Vijay Bhaskar. He is a unit commanding officer at Indian Navy Health Services, Jivanti, which is there in the Vasco, just few kilometers from here. Academically, he is an alumni of Armed Forces Medical College in Pune, MBBS and MD from the same institute. He is WHO Fellowship on Health Impact Assessment, University of Liverpool, UK, and his officer's CBRN basic course at CME Pune. He is MD in communication, community medicine. He has received several academic awards, the DGA FMS Gold Medal for standing first in advanced course at AFMC, Maharashtra University of Health Sciences Gold Medal for standing first in University for MD Community Medicine, Outstanding Officer Award and Certificate at Medical Officer Senior Command Course, Lucknow, and several military awards like Commander-in-Chief WNC Commendation twice and Commander-in-Chief at Andaman and Nicobar Islands Command. Appointments held are several. He served on board INS Investigator and INS Bias, Senior Staff Officer Health, Western Naval Command, Officer in Charge Station Health Organization Mumbai, Officers in Charge Station Health, DG AFMS Minister of Defense, District Medical Officer CG DHQ10 and Professor Department of Communication Medicine. He has several publications to his credit, around 25 publications in national and international journals have been published. He is Assistant Editor for Standard Treatment Guidelines, Minister of Health and Family Welfare, Assistant Editor for Red Book Manual of Public Health for Armed Forces, and contributed chapters in books for food safety as well, and contributed chapters on book on COVID published by Armed Forces Medical College. So I request Chief Guest Surgeon Captain Dr. S. Vijay Bhaskar to say a few words. It's a dual person whom we honor, the Defense Forces as well as our own medical man.
Thank you, Dr. Suresh, for giving such a elaborate description. I am actually not that great. I don't deserve so much. My staff officer, I asked my staff officer to send a biodata, and he sent this. So I'm feeling ashamed for that such a long biodata. When you are in front of such a luminaries on stage and people who are so who are experts in their field, I am little bit of afraid what to speak. But once one of my teachers said, if you have seniors in front and seniors by the side, you need not worry. You can do anything, you can speak anything, and you can make mistakes, and they will forgive you and forget it. So if I make any mistakes, please ignore me. I'm not naming because I'm not conversant with all the names. So sorry, sir. And after an eloquent speech by sir, I need not speak because there's nothing much to speak. So well, he is elaborated on sexual health and sexology. I really don't think I can speak much about it. Personally, I am from Armed Forces Medical College and I've done my MD in community medicine. I've served around 20 years in the field of public health. My interests are infectious diseases, immunization, and maternal and child health. So when I'm sure many people would have thought that chief guest koi buddha hoga ya fir koi some elderly hoga. And when I'm here, I am feeling sorry. I should not have been sitting there. I should have been chupchap sitting there and listening to the great people sitting here. So, Mr. Dr. Shirish, next time you should call somebody senior, maybe. Yeah. I convey my compliments from my flag officer Goa area Admiral Penamutul sir, who was supposed to come, but because of some commitment, he could not attend this meeting conference. So he requested, Bhaskar, why don't you go? So I said, as the subordinate, I said, definitely, sir, I'll definitely go and attend. But I never knew, okay, I'll have to sit here and give a bhashan also. But yes, the topic is very close to me and very near to everyone, I'm sure, but nobody wants to speak about it. We always think issue is from the people or a common man who doesn't want to speak. For me, I feel issue is from us who are experts. We also don't want to speak. I'm sure not many of our medical fraternity or the educated crowd would like to or would speak about sex or sexual health or sexology in an open forum. And we all are afraid and we have some inhibition to speak. So I think first we need to get educated much more than what we need to educate the public or community. Once we are educated and we are clear in our mind that this is an important topic and we need to discuss, then we can take this point to the masses or public as a whole. With this gathering, with the experts from all fields, I'm pretty sure that we are going in right path and we'll do a great job in coming futures. I was just going through the entire schedule of the program, 2 days program, the types of the topics which have been selected from all the corners, including Ayurveda. It's a great feast, and I'm sure the entire delegates will have a great time during the conference. All the best to the organizers, and thank you so much for inviting me and calling me and honoring me. I'm honored, sir. Thank you so much, sir.
Thank you, Surgeon Captain Vijay Bhaskar. Now I request Secretary of CSEPI to give a vote of thanks for today's inauguration program. A couple of things I would state till the time the madam comes here. Today's schedule is there with you. If not, then you can collect it from the table. The writing pads are also here. And since we are little behind the schedule, because in the morning everyone was little more occupied with the seaside, taking photographs and various other activities. So the tea break, we will be making a working tea break. We won't be stopping our scientific sessions. The tea would be served there and scientific sessions will be going. So my humble request not to gather and not to make chaos at the tea counter. Take your cup of tea and get back to your position. Take a small sip by sip and you listen to the scientific talks as well. Okay. Thank you.
A very good morning to you all. Namaste to you all the dignitaries on this stage, off this stage, my dear friends. Now it is my pleasant duty. I take my pleasure and privilege to thank all the people who are doing part of this great inaugural function. And first of all, I would like to thank Dr. Shirish Malde for giving me this opportunity to render the vote of thanks. And I congratulate him for his perseverance and the grit in arranging this conference. From the past 2 years, he has been taking so much pains to arrange this conference in such a beautiful place as Goa. I thank Dr. Sanjay Deshpande for giving the presidential address. And I am highly thankful to our chief guest, Surgeon Captain Vijay Bhaskar, and he's so punctual, came so early, right on time. I feel sorry for that. I kindly excuse us for the little delay which happened. Thank you very much for your kind words as chief guest. And I am profusely thankful to our guest of honor, MLA Moin Godino. And in spite of the busy schedule, taking time off and gracing this occasion, and I was really surprised to hear such nice words from him and such a beautiful speech he could give, and with so much of good advices, and he has analyzed it so well. And I understand why he is so popular among people, with such a good speaker, knowledgeable, and also to the point and very relevant talk. And he spoke the importance of the diet, exercise, and specifically exercise, the quality of life, the importance of knowledge and discussion about the sexual matters, and which is very important when the quality of life is there. And we should give quality of life to our children and enlighten them about these sexual matters in a proper way, in a knowledgeable way. Thank you very much, sir, for that wonderful speech that we could give. And I thank Dr. Raj Brahmbhatt for remembering our colleagues and paying our respects to them. And we are really missing all of them. They were all always a part of all these conferences, and we are really missing their presence. And I congratulate and thank all the icons of sexology who received the awards, Dr. Raj Brahmbhatt, Dr. Prakash Kohari, and Dr. Narayan Reddy in his absence. And they have contributed a lot for all these things. And I thank Dr. Venkatramana for his presence and his guidance in conducting this conference and about the scientific matter. I thank all the delegates who have come here, and without you all, and conference will not be a great success. So I thank you, each and one of you, and I thank all the former partners, media partners, and all the people who are directly or indirectly contributed to this conference. So wish you all the best. I wish all the success for the conference. Thank you, one and all. Thank you very much.
Thank you, Padmini ma'am. Vivek bhai, just the stage arrangement would get changed. Meanwhile, you can all hold a cup of coffee or tea. According to this program, I request the chairpersons to be around the stage. So once the table is arranged here, you can immediately occupy the position and invite our next speaker. So invite our next speaker and we'll start our session immediately.
Good afternoon, friends. We are about to start our session. Can I ask our first speaker, none other than Dr. Sanjay Deshpande, to come here, and the chair people over here. Right, my friends. Now come back to your questions. Now scientific program is starting. I invite my co-chair, Dr. Bhaskar.
Now today, the first session is plenary on the commonest sexual problem that every practitioner encounter in India, not only in India, across the world, is ejaculatory problems. Among the ejaculatory problems, the commonest being early ejaculation or premature ejaculation. To this, I am placing you a luminary who did lot of work in this area, and he is none other than our chairperson, CSEPI. He is not only chairperson, he is having lot of positions in other organizations like President IMA Nagpur, President IMA Maharashtra, past President Special Interest Group of Sexology in IMA, and presently he is a professor in HOD Department of SPM. He is none other than our Deshpande, Sanjay Deshpande. Now I request to say a few words about the speaker from my co-chair.
Anyway, good morning, everybody. Now it is time to move on with our scientific program. And the opening batsmen are the beginner with a good start and with a good message and with a commonest problem, how to deal with that. For that, we have our great speaker, Dr. Sanjay Deshpande, and he needs no introduction. And it is, let us see what he is. I don't want to waste much time. So over to Dr. Sanjay Deshpande to start his lecture. Thank you very much.
Thank you, Dr. Padmini. Thank you, Dr. Venkatramana, for introducing me for so long. And in fact, I am a small man. Just because of position, I am here. But I know.
He wants long introduction, not early.
So my presentation, please. My presentation, please. Thank you. So friends, I will just start my speech here only without waiting for the PowerPoint presentation. We all know that erectile dysfunction is the most commonly discussed topic in sexual medicine. Forget about sexual problems in females and forget about sexual problems in males other than erectile dysfunction. We don't discuss much more about any sexual dysfunction than erectile dysfunction. And that's why my presentation is on ejaculatory dysfunctions. Next slide, please. Can I move? Yes. As you know, my topic is on ejaculatory disorders. Now, when we define ejaculation, ejaculation is nothing but passing of semen in after sexual stimulation. But many of us may not be knowing, even I was also not knowing before my studies, that ejaculation is not a one-way process. It's basically divided into 3 stages. First is the emission. Okay. First is the emission. This is the pointer, I think. Where is the pointer? Okay. The first is emission when the semen is in the common prostatic urethra. Oh. Where is this pointer? Last one. Okay, okay. So as you know, that the first phase is when the semen, which is a mixture of spermatozoa from testes, prostatic fluid and seminal vesical fluid, is excreted into prostatic urethra. Now this is a phase which is also called as ejaculatory inevitability. The word itself is very crystal clear that once this process starts, then nobody can stop the ejaculation. Next step is ejection. That is the second step, when all the periurethral, bulbocavernous, pelvic floor muscles, they rhythmically contract and ejaculate the semen from the external urethral meatus. And third is orgasm. After this, then the person who ejaculates feels or have a pleasurable sensation. So these are the 3 steps. But usually we take ejaculation is equal to orgasm, which is not correct. We have to understand that. Now, classification of ejaculatory dysfunction. Now, we always, being a learner or beginner in the field of sexual medicine, or for that sake, as a common individual also, or common doctor also, we feel that ejaculatory dysfunctions means only premature ejaculation, nothing else than that. But there is a complete list of it. Now, these are all the ejaculatory dysfunctions. As we always know, that premature ejaculation, which is very important dysfunction, and I can, in our latter part of the talk, we can see that the incidence and prevalence of erectile dysfunction is less than premature ejaculation. Premature ejaculation accounts for nearly 25 to 40% of the male in the sexually active group. So it is a huge burden. But unfortunately, the patients, because they are sufficient enough or capable enough to do sexual intercourse, they don't go often to the doctors or a sexologist. And their female partners, usually, they are not satisfied, but they also cannot do anything, so they keep mum. So this is the silent killer of the sexual problems, or silent killer of the sexual pleasure of a man and women both. Then primary delayed ejaculation, acquired delayed ejaculation, retrograde ejaculation. We'll say one by one all these things. Anejaculation, anhedonic ejaculation or anorgasmia, hypohedonic orgasm, painful ejaculation, and post-orgasmic illness syndrome. Now in ICD-11, there is a revision, and these are the male early ejaculation, male delayed ejaculation, retrograde ejaculation, other specified ejaculatory dysfunctions, and ejaculatory dysfunction unspecified. And again, they have categorized these first 2 into 5 categories. That is lifelong generalized, lifelong situational, acquired generalized, acquired situational, and unspecified. And this is a new Japanese version which I wanted to highlight you because it is a very simpler one and easy to understand. Impossible to ejaculate. There are many people, or there are few people we can say, or some people rather, they can't ejaculate at all. Both by masturbation or intravaginal ejaculation are impossible. They can be either retrograde ejaculation or it can be an ejaculation. Again, it is divided into emissionless or expulsionless. And second is intravaginal ejaculatory dysfunction. A patient can ejaculate during masturbation, but not during sexual intercourse. An abnormal time of ejaculation, where this most common sexual dysfunction in man, either it can be lifelong or acquired, and delayed ejaculation. Pain during ejaculation and anhedonic ejaculation. Now, what is retrograde ejaculation? Usually, after that first phase of emission is over, the the semen passes through the urethra and come out of the urethral meatus. But in retrograde ejaculation, it doesn't happen because the neck of the bladder doesn't close. The semen passes retrogradely or backwards, and it mixes with the urine, and this is called as retrograde ejaculation. How to diagnose the condition? The condition arises when semen released in the posterior urethra flows back into the bladder, and it should be diagnosed by more than 5 spermatozoa per high power in urine sediment immediately after masturbation. Either it can be immediately after masturbation or it can be post-coital urine. Now, there are people who are indulging in sexual activity. We can definitely ask them for the post-coital urine examination. And if the spermatozoa are present more than 5, then it should be called as retrograde ejaculation. Causes of retrograde ejaculation, there are many, mostly because of different pelvic and lower abdominal surgeries. If there is a injury to the nerve supply, then most of the time retrograde ejaculation occur. But most common procedure is transurethral prostatectomies and transurethral bladder neck incisions. Some cases are due to drug side effects also, many of the psychotropic drugs, and diabetes also, because of various diabetic neuropathies, it can also develop retrograde ejaculation. Drugs that can cause an ejaculation or delayed ejaculation are plenty. Psychotropic drugs, SSRIs, and that's why these SSRIs, many are used in the treatment of premature ejaculation. These NRIs also can be a cause of delayed ejaculation or an ejaculation. Drug for prostatic diseases, drug for androgenic alopecia, drugs for hypertension, epilepsy, HIV infection, and drug for erectile dysfunction. It may not be 100% true because, but in some cases, we have found that even after giving sildenafil and tadalafil or vardenafil, people, they don't ejaculate. So PDE5 inhibitor also have a major role in treatment of premature ejaculation also. And ejaculation. Now, as we said that the ejaculation process is of 2 steps, there can be 2 types of anejaculation. One is emissionless, when the patient is unable to discharge semen into posterior urethra. So I take this as a primary anejaculation. Though the word is not there, literature doesn't say that, but this is the primary anejaculation. But second one is expulsionless, when the patient is unable to vigorously discharge semen from the external urethral meatus. This can be possible in elderly people. They ejaculate but very less. The ejaculation is not that forceful. So people have always a complaint that their ejaculation is not forceful and it dribbles down. But of course, it should not be included in an ejaculation because there is some ejaculation there. But the author has given that definition. That's why I have included there here also. Then causes of anejaculation. Again, same of what used to be retrograde ejaculation. Because the most important reason of anejaculation is either retrograde ejaculation or primary anejaculation. So whatever the causes of retrograde ejaculation are there, they are also causes of anejaculation. Caused by drug side effects, we have seen because of Klinefelter syndrome, pituitary disease, hypogonadotrophic hypogonadism, and anatomic obstructions of spermatic transportation ducts such as Mullerensis, congenital bilateral obstruction of the vas deferens. This can very well be diagnosed through the ultrasonography. There are also rare cases of no evidence of organic disease. Then comes the real anejaculation or intravaginal ejaculatory dysfunction. This is very interesting. People are able to ejaculate through masturbation, but they are not able to ejaculate inside the vagina during sexual intercourse. There are 2 types of intravaginal ejaculatory dysfunctions, with or without ED. But I don't take that with ED, it's erectile dysfunction which is important. But for better understanding, I usually ask patient, whenever I want to diagnose a case of delayed ejaculation or an ejaculation, whether you lose erection because you don't get ejaculation. That is one thing. Or whether you get erection, but you don't ejaculate at all. So first step is that because he is losing erection, that is erectile dysfunction. It is not delayed ejaculation. But even after so much of time, he doesn't ejaculate, the penis is erect, then only it should be taken as a delayed ejaculation or an ejaculation or intravaginal ejaculatory dysfunction. And the cause is mostly, many times they come for treatment of sexual dysfunction and male infertility. Now, ejaculatory dysfunction, intravaginal ejaculatory dysfunction with ED. Now, this is very common whenever the couples are going for the treatment of infertility. Many times a man, he can give semen sample, but because of psychological pressure, he loses erections during coitus after sufficient period of time also. But it is usually erectile dysfunction, so we cannot say that it is delayed ejaculation. But this is, of course, a true intravaginal ejaculatory dysfunction without it. So erection is there. So our first differential diagnosis is clear now. It is not erectile dysfunction. Then only we can say that it is the intravaginal ejaculatory dysfunction. Usually, there can be two types of intravaginal ejaculatory dysfunction, though masturbatory ejaculatory dysfunction should not be here. But for better understanding, during treatment and diagnosis of infertility, many times, Dr. Padmini must be knowing it very well, many times the males, they don't ejaculate even during masturbation also. When they are asked to go for collection of semen, they can't ejaculate. Many times they can't get erection, or sometimes they get erection but they can't ejaculate. So that can also occur. And another is coital. Means they ejaculate during masturbation, but they don't ejaculate during the sexual intercourse. So there is an interesting correlation between ejaculatory dysfunction and masturbation. The author of the study, they actually basically tried to tell it for the delayed ejaculation only. But I can tell you, this is a very common condition. Venkatramana also will vouch with my observation that it can affect both premature ejaculation as well as delayed ejaculation. Masturbation is supposed to be associated with different ways of ejaculatory pattern. Masturbation without using hand, a hands-free masturbation from adolescence by rubbing or pushing against something often causes intravaginal ejaculatory dysfunction. This is very common. So whenever in delayed ejaculation, what we say is that bridge or maneuver, which we usually ask them in sex counseling, that is not effective during this in these patients because they don't masturbate or they don't rub the genitals vigorously. If a patient is not alone during masturbation, he cannot ejaculate. Same thing can happen in coitus also. One of my patients, I distinctly remember, they were having a small room and they said, one room my parents are sleeping, another room we are sleeping. And after that room, there is a bathroom and kitchen. So whenever my parents, because of older age, they go for urinal in the night, we can't perform. Even if I perform, I can't ejaculate. So I give them a simple solution. I said, you only change your bedrooms. Okay, you sleep in the first room, ask your parents to sleep in the next room so that they did not disturb you. And let me tell you very frankly, from the next day, their problem solved. So many times it is that somebody will be coming. These people, they get erections. Sometimes people don't get erection also. But these people that they get erections, so thereby their wife is satisfied, but he is unsatisfied. And the fertility doesn't take place. So that is the big worry for them. Gripping the penis is too strong during masturbation. And such type of patients are large in number. For masturbation or for ejaculation, they want a vigorous stimulation, which is not possible in intravaginal sexual intercourse. And because of that also, they don't ejaculate intravaginally. Then phimosis related. Non-piston movement, as I told you, they don't rub their penis as it is being rubbed during sexual intercourse. And that's why they don't ejaculate. And fetish, people who cannot ejaculate without a specific thing will have difficulty in intravaginal ejaculation. Then comes the most important topic. And this is called as bread and butter of sexologists, I can say. Out of 10 people, 4 to 5 people will be definitely from premature ejaculation. It's a pathological condition in which the time until occurrence of ejaculation during intravaginal insertion of the penis is short. For this reason, P is defined as a case where sexual life is negatively affected, such as pain, annoyance, frustration, and avoidance of sexual intimacy for the person or partner. Lifelong or acquired. Lifelong means from the first sexual intercourse itself, the patient is or the person is having early ejaculation. Our Dr. Kohari, our pioneer in sexual medicine, he used to say that premature ejaculation is a wrong word. We should call that early ejaculation or early orgasm. And acquired premature ejaculation, basically, patient has earlier good ejaculatory control, and later on they don't have. And they have defined it is in the intravaginal ejaculatory latency period also. If it is less than 1, then it should be lifelong premature ejaculation. If it is less than 3, then it can, or more than 1, it can be in the acquired premature ejaculation. Delayed ejaculation. Now this is not possible in India because the ejaculation time of Indians or Asian for that say is less than the Europeans and less than the Africans also. Africans have a longest ejaculatory time followed by Europeans and then by Asians. So it is not, basically it may not be for India, 25 to 30 minutes. Then pain during ejaculation, maybe because of prostatitis or prostatic hyperplasia. These people, they get the pain. The patient distinctly tells that I get burning ejaculation, burning sensation or pain after my ejaculation. Usually pain before ejaculation or a person who is very excited sexually but doesn't ejaculate, he get pain. But here it may be exactly reverse. After ejaculation, the patient gets the painful sensation. Anhedonic, that is non-enjoyable ejaculation. The name itself is there, so I am not going into the details. Now, how to diagnose ejaculatory dysfunction? This is very important. And most important thing is sexual history. See whether it is a lifelong or acquired. Frequency of sexual intercourse is also very important, because if the frequency is too less, the person may have premature ejaculation. If frequency is too large, too common or too high, he may have the delayed ejaculation or an ejaculation. Many people, they come and tell, Dr. Sahab, sex hota hai lekin dusri baar mein veerya nikalta hi nahi. This is a very common symptom. So we'll have to tell them, educate them that that may be a normal phenomenon also. The history of medications, usually the patients referred from psychiatrist, because many times there are some psychotropic drugs which are prescribed to them, and because of that also they are not having ejaculation. So that also has to be taken care. Any disease like diabetes, whether erections are not present, because in premature ejaculation also it may happen that person is having erectile dysfunction and immediately after some time he ejaculates, like what we say, emissionless and ejectionless. So in ejectionless, delayed ejaculation, they don't get erection, but their prostatic fluid is their semen is already in the prostatic urethra, and because of that they don't ejaculate, but after some time they ejaculate. So basically it is because of erectile dysfunction rather than the disease is premature ejaculation. And partner specific. If there is a new partner, then chances of early ejaculation are more. This is already discussed. If frequency is very less, then premature ejaculation can be common. So treatment cannot be only drug therapy, but we can counsel them, ask them why their sexual frequency is less, and we can correct it by proper counseling. Partner specific, marital status, partner's response, staying together or distance marriage. Delayed ejaculation, again same. You have to identify whether it is because of coital or masturbatory both. Because if they are having long time for masturbatory and ejaculation and they are not getting ejaculation during sex, that can be intravaginal ejaculatory dysfunction. Medical history again, any psychotropic drugs, and ejaculation. Now in an ejaculation, just to differentiate whether it is a retrograde ejaculation or not, this history is very important. Nocturnal emission. Now those people who have history of nocturnal emission, very common word is nightfall. If they are having nightfalls regularly, it means it is not retrograde ejaculation. It can be an ejaculation apart from retrograde ejaculation. And of course, medical history of any pelvic surgery. Rule out retrograde ejaculation, I told you, because of this presence of nocturnal emission. Then there are two types of anejaculation. We have already discussed it. One is emissionless, another is expulsionless. But there is very difficult to distinguish. So history taking is the only thing which is important. You have to take history in very, very minute details. Patients sometimes are very irritated that what doctor is asking. But I usually tell them that I cannot observe you when you are doing sexual intercourse. So it's what happening in sexual intercourse has to be known to me before guiding you. And many times the couple therapy or couple counseling helps us more, because the women partner can tell exactly better things than the partner alone or the husband alone. So if it is possible, we should always ask a man to come with his partner or wife. But it is very difficult, I can tell you, that these people, they don't tell their wives that they are going for treatment. They want to keep it secret. So that is a big problem in India. So definition of PE we have already seen. These factors are young age, high levels of education, divorce, social phobia, lower frequency, high levels of intercourse related anxiety, greater impatience, and impairment in sexual relationship satisfaction. Due to psychologically over anxious personality, the treatment is psychosexual counseling, pharmacological treatment. There are number of drugs, but I will tell you the most important drug here is this paroxetine, because it can be used in both way, in daily treatment as well as on-demand treatment. Then clomipramine, sertraline, fluoxetine, these are also important drugs. On demand means whatever we are giving PDE5 inhibitors 1 hour before sex, 2 to 3 hours before sex, whatever we say, that is called as on-demand medications. And on-demand medications are useful in people, those who are not having regular sexual intercourse, mostly unmarried males or elderly population, whether there are numerous other medications that are going on and we can't put them on daily doses of all these antipsychotics, or even the patients who are suffering from some psychiatric illnesses, they are already on the treatments by the psychiatrist, then you cannot give them the regular treatment. In such cases, we should opt for on-demand treatment. Now, this is the most important new drug, maybe marketed since last 4 or 5 years, of course, not a new, but this is specifically marketed as a drug for premature ejaculation. Otherwise, whatever drugs we are using, they are in the treatment of mostly depression or OCDs. And then we are using them for the treatment of premature ejaculation. So we have to know this, that this is a very useful drug which can be given to the patients who are not having regular sexual intercourse. Then tramadol also is used. Sildenafil, tadalafil, vardenafil, these drugs many times help patients of premature ejaculation. And my one suggestion, of course, that is not substantiated by any clinical study, but I am doing that many times ejaculatory dysfunction means premature ejaculation is associated with some sort of erectile dysfunction also. And that's why if the erectile dysfunction also is simultaneously treated, we have a good or better response to premature ejaculation of these patients. And this is most important. Many times premature ejaculation is common with erectile dysfunction. And that's why we need to treat these patients of premature ejaculation with PDE5 inhibitors also. These are the various drugs and their meanfold increase.
Dr. Sanjay, how many more slides you have?
I will curtail it. How much time is left?
Another 2 minutes.
Okay. So these are various drugs and their response, paroxetine is on the top. Medications for premature ejaculation, there is a complete long list. Sorry. Behavioral therapy for premature ejaculation. Components are, I will quickly summarize them: assessment, general history, sexual history, relationship history, understanding of sexual anatomy, because sometimes they don't know the sexual anatomy and that's why they ejaculate outside vagina and they feel that it's a premature ejaculation. Behavioral components: senses, focus, squeeze techniques, stops, Kegels exercise. Treatment for anejaculation, there is a complete list of many drugs. So thank you. I could not take the detailed treatment part.
Yeah, participants, if you are having any questions, you can interact with the speaker at lunch hour. Because of time constraints, we are moving to the. Thank you very much. Now I invite the second session's chairpersons, Dr. Suresh Rudrappa, Dr. Vinod Vijay. Please come and occupy the chair and conduct the proceedings, please.
Okay, thank you, chairperson. Thank you, audience.
And wait. The upcoming chairperson will give the memento. One. So ladies first, I think. No. We should Venkatraman. Yeah. And now. Yeah.
Next session. Vijay, please. Yeah. Rudrappa.
Organizing secretary. So, yeah.
Well, we are just at 12 o'clock. So before saying good morning or good afternoon, it's indeed a great pleasure. I first thought I would be like fish out of water as an interventional cardiologist attending this meeting, because it's a very relevant topic. I am planning to set up in my own corporate hospital, sexology clinic. And who would be a better person than the organizing secretary, Sirish Malde? For me to sort of introduce him would be like showing a mirror to sun. So he's such the way with which he has organized with the passion, but yet it's customary that we have to speak. So Sirish Malde You all know, of course, he's MD from Maharashtra University of Health Sciences, a diplomat of American Board of Sexology, a consultant in sexual medicine and male infertility, having practiced in Mumbai since 21 years and visiting consultant at Goa and Belgaum. I will be adding Nasik and Pune. So in the next, yeah. He is the ex-joint secretary of CSEPI and organizing chairman of this current National Conclave of Sexology Goa, which he has really conducted so well. He is actively involved in sexuality education among the young adults. He has wide experience of running a telephonic helpline addressing sexual and reproductive issues of the common people. He has answered more than 65,000 calls. He is a resource person to many social service organizations and trainer for sexuality and reproductive health. He has presented many scientific papers on various platforms. Socially, he takes regular programs for creating awareness about sexual health for general public and pre-marriage counseling programs for the youth. So with this brief introduction for such a great personality, it's a proud privilege to chair your session, Dr. Sirish, and I would request you to start with your lecture.
Thank you, Dr. Vijay, for praising me to some extent.
Dil se, cardiologist too.
Accepted, that too dil se. Even though sexologist too. Except dil se hi hoga. So friends, the topic is setting up sexology clinic. This topic was selected by our Venkatraman sir, keeping in mind our new plethora of the new medical practitioners who are now, deciding to choose good clinical practice in the field of sexual medicine. There are more than 4 decades and 5 decades practicing practitioners here. So for them, I think this would be, like showing them the mirror. That's not an effort, and at the same time, I would say that this is not an exhaustive guideline that I have mentioned here. Each one of you, depending on your locality, depending on your socio-cultural milieu, you have to decide about setting up the sexology clinic. Okay. So we'll begin with this. What is the basic requirement to start a sexology clinic or to have some part of your practice into sexual medicine? What would be the most important feature necessary is the new mindset. If you want to achieve something new, you have to do something new which you have never done so. And being clinical practitioner, you may be a successful clinical practitioner, you may be a successful general practitioner, you may be a cardiologist, you may be gynecologist, you may be dermatologist or psychiatrist. But to be a sexologist, there are certain prerequisites, I would say. Being doctor doesn't entitle you to develop those abilities. जैसे एक लड़का हस्बैंड बनता है तो उसमें कोई ज्यादा डिफरेंस नहीं आता है, लड़की अगर पत्नी बनती है तो उसमें बहुत डिफरेंस आते हैं. वैसे कोई मेडिकल ग्रेजुएट डॉक्टर बनता है तो उसमें ये एडिक्वेट जो क्वालिटीज है वो आएगी, ये जरूरी नहीं है. इट नीड्स टू बी नर्चर्ड. The person should have adequate knowledge and he or she should be comfortable with their own sexuality. First and foremost requirement, I should say. If you are not happy, if you are not comfortable with it, you will not be probably become a good clinician in sexual medicine. You should have learning attitude. अरे यार इनको तो मैंने 4 बार सुन लिया है, ये टॉप तो एकदम हर कॉन्फ्रेंस में मैंने अटेंड किया है, अभी ये टॉक की मुझे जरूरत नहीं है. When you develop that attitude, you stop growing and you stop learning. Even if the topic has been discussed from other speakers, but still you should develop and you should maintain that flame into you to learn new things again and again. Most important, good communication skills. I recently told you that if you are a good doctor doesn't mean a good communicator. Many times you see the highly qualified doctors may not have a good practice, but an average qualified person or sometimes even non-MBBS person will have a very flourishing. I'm talking about the general practice. That's the only difference makes is the communication skills. People will remember how you made them feel. They won't be impressed by your long degrees or from which university you passed, but they will remember talking to you how they felt. Patience, most important. Often for many years when we have practiced, we tend to ask few limited questions. We make our own, we presume the clinical diagnosis and we prescribe the medicines. But no, here the patients would be very much essential, because all patients will not come and say, sir, mere ko ye hota hai, mere ko wo hota hai. They may start with some vague complaints. I have general body ache, kamar mein bahut dard hota hai, particularly females. They, even if they go to a gynecologist or their general practitioner, their family physician, they may not immediately or openly say about the sexual issues or their intimate issues. They would start with some non-specific vague complaints like gardan mein dard hona, neend nahi aana, sometimes ji machalna, some of their symptoms you will not find in any of the medical books.
Sorry to interrupt. There is a parallel session going in other hall. People are not aware. So the organizers have said that hall is empty. So you please go through the program. I know we have got such a luminary here on this side. So it's very tempting not to leave this hall. But there is a parallel session and we have to announce so that those who may wish to go there, because we got a complaint that there is, just like we said, that some doctors are very, very successful. So it's the same thing is happening here, a practical demonstration.
Keep the timetable handy in your hand and select your preferences, I would say, because of, to accommodate more sessions, we have to divide 2 halls. In fact, in Foxy, there are 7 or 8 halls running simultaneously. So one has to select the preferences. So coming back to this, patience and willingness to hear. The most important part to be a counselor, to be a good counselor and good clinician would be willingness to hear. Good vocabulary. You cannot use the same word what you use in other slangs for the private parts. You have to use the word like Shishna, Purush ka Guptang vagere. You cannot use the word L. You cannot use the word for the even for the counterpart in females also. So one has to have a very good vocabulary which is socially acceptable and should not put the patient in a very uncomfortable position. And finally, empathetic attitude. I'm not saying sympathetic attitude. To be a good counselor or clinician, one should empathize the client and not sympathize. If someone is really in a sad state of their marriage, if you go on sympathizing, you will not be an effective counselor. You will not be able to help the client. You can empathy them. And when you enter their frame of reference, you confirm that आपको 3 साल से इरेक्टाइल डिसफंक्शन है, आपको काफी समस्याएं आई होगी, आप मानसिक रूप से बहुत परेशान हुए होंगे. He said, हाँ, exactly sir, exactly यही मुझे हो रहा है. Once they confirm this, that means you have entered the frame of reference. This is their acceptance that you have understood them well. And once you reach and once you have that connect with the client, you will be an effective communicator, you will be an effective counselor for them, and you will be able to enable the changes that are required in that client. And most important, non-judgmental attitude. We immediately jump to conclusion. किसी को कुछ देखा बीच पे, किसी को थोड़ा सा short उसका थोड़ा और ऊपर हो गया, तो immediately we jump to conclusion about their character, about their nature. वो तो ऐसा ही है, वो ऐसे ही है, ऐसा. So don't jump on the conclusion just based on their personal background like caste, profession, religion, क्लोथिंग एंड हेयर स्टाइल्स, लंबी पोनी रखने वाले गे होते हैं, कान में बाली रखने वाले भी इस तरह की MSM एक्टिविटी रखते हैं. You know, all this kind of pre notions are there in people's mind. So as a clinician, we should wipe out everything and attend the client in a non-judgmental attitude. They may come up with the things which may be little uncomfortable to you, or you, I mean, that may be not agreeable to you on your personal level, but that doesn't mean that you have to if you reveal it to the client, they will not confide in you. If they are bringing the subject of gender dysphoria or altered sexual orientation, and if you are uncomfortable at it, and if they sense it, they will say, bye bye doctor, I think you will not be in a position to help me. They may not say you on face, but they may not come back again to you. Gender and sexual orientation, I already talked about. Sexual practices, some of them may come up with some weird sexual practices as far as their foreplay is concerned, as far as their arousal requisites are concerned. You may come across a person that if my partner urinates on my face, I feel a lot of sexual excitement. I feel aroused only when she does fingering in my anus. And you say, Gandhi Sali. And you know that it's finished. You are no longer a doctor for them. So such things you have to accept in a very neutral way. Your face expression should not reveal anything that you have become uncomfortable towards it. And when you will achieve this, when you really develop non-judgmental attitude, you will not be able to hide your expressions. You will not be able to conceal what is going in your mind, because the opposite person who is trying to connect you psychologically will immediately sense what is going in your mind. So you have to develop this attitude that you really become non-judgmental. And about their lifestyles, someone says ki I sleep only at 5 a.m. in the morning, then I wake up at 8 o'clock, then again I go to bed at 1 o'clock. He said, क्या कैसा तुम्हारा नींद का आदत है और कैसा तुम्हारा लाइफस्टाइल है, ऐसे कोई जीता है क्या, ऐसे कोई सोता है क्या? And it's not good. Now coming to the physical setup of the clinic, these are only some important guidelines. It's up to you. खिचड़ी में आपको घी कितना डालना है. You can have an interior for 1 crore, 2 crore also, and you can start with few thousands also. Most important thing is privacy. The consulting room and in waiting room as well. In places like Mumbai, we don't face that problem in waiting room much. But wherever I have gone to the smaller towns, they immediately say, doctor, can I see you somewhere else? Where do you stay? Where have you been put up? I would like to come there. In the clinic, there are so many people knowing me in the surrounding. And if I come to your doorstep, I will be immediately labeled as a person who is seeking help of a sexologist. So in the small towns, yes, I mean, you cannot keep your main door open. As Dr. Prakash Kohari yesterday said, his door always remains closed. In fact, when a person enters, the receptionist does not ask their name. They do not say, Mera naam Shirish Malde. Because there are 2 or 3 other in the waiting room will also come to know that Shirish Malde karke inke paas aaya hai. So even that confidentiality is also maintained. He has made a small slips on which the client who has entered the waiting room writes his name and handles it to the receptionist. Receptionist takes this slip inside the doctor's chamber, and then doctor decides when the person should be called. So that much of privacy has to be maintained. In most general practitioners, many of them, they have their table right in front of 10 other patients. Sometimes their compounders are also standing just few feet away, or sometimes their assistant doctors are also there. You know, very busy physicians or cardiologists or even general practitioners may have a couple of juniors or assistant with them. So many of the clients may not approve of having even assistants also. Even if you say, नहीं ये भी doctor हैं, ये भी हमारे साथ ही रहते हैं, मेरे साथ 5 साल से हैं, but still they may not approve it. डॉक्टर आपसे ही अकेले में बात करनी है. So provide them privacy in consulting room, enough space to discuss sensitive issue. जल्दी बोलो, अभी 5 मिनट में मेरा क्लिनिक बंद होने का टाइम है. He will not be comfortable to open up. Spacing of the clients. Don't take 20-30 clients in a day. Of course, to reach to that level, one has to work for many years, particularly in sexual medicine. So space your patients. Maybe 15 minutes each you can give appointment. New patients 30 minutes. Don't jumble, crumble up. Patients may have an habit. डॉक्टर साहब मेरे को कल मैं नहीं आ सकता, मैं आज आ जाऊं क्या? They may press upon you to accommodate them even sometimes without appointment. It's absolutely on you whether you prefer to see patients with appointment strictly or without appointment. Also, you will squeeze the patients from your regular patients or so, something like this. Preferably, you have different timings if major of your practice is something else. Dr. Vittal Prabhu, our past president and our mentor, teacher, he had kept one day, Wednesday, for sexual medicine, and rest of the day he used to be the general practitioner. Absolutely fully busy man, 80 patients in the morning, 50 patients in the evening session, more than 150 patients he used to see. But then sexual medicine kab karega? Wednesday. Afternoon 1 to 6 or 1 to 7, he used to space the patients. How many number? 8-10 patients he would space in that 6 hours and will do the sexology practice in that time. So if it is so, you give us special different timings. Our one more fellow from our CSEPI, morning, evening, he has a different practice of radiology. Afternoon, he becomes sexologist. So you can develop something like this. Nothing wrong into it. Case records to be kept confidential. Many patients are very much particular that ये फाइल आपके पास रहेगा, केस पेपर आपके पास रहेगा, मेरा पर्सनल डिटेल्स है, फोन नंबर है, मेरा चीफ कंप्लेंट लिखा है, मेरा हिस्ट्री लिखा है, मेरा प्रिस्क्रिप्शन लिखा है. And if you have a habit of maintaining their carbon copies or so, they would like to see that none of the other clinic staff has an access to it. And it's a good practice that you don't give access to the other non-clinical staff of these case papers. Nowadays, there are many companies who have come up with their startup apps and their softwares of patient management system. Many of them, they are offering free. Bajaj Finserv, many of you would have been bombarded with SMS. You download this app and you do this, that. You schedule your appointments through our app. You may find it nice and happy, but you have to use these softwares judiciously, because it is said that no lunch is free in the world. That means if they are offering their app free, if they are offering their intellectual property, if they are offering their software free for your use, what they are earning from? They are earning from the data which they gather from your clients. When your client is taking an electronic media based an appointment, or you are scheduling him on your app, in that case, you are giving all data to the company. Company has an access to everything on your app. They may not tell you, they may not disclose it to you, but they are gathering each and every information. And to my surprise, even Practo, Librate, if you write the mobile numbers of the client, they start SMSing the clients without your knowledge. They may start bombarding their own products to the patients. So never disclose the mobile numbers on any of these softwares.
Last 2 minutes.
Adequate lights in consulting room. Don't make it like a restaurant. And decent interior. It may not be very expensive. Basic skills, proper history taking. I may not go into detail. Avoid unnecessary and irrelevant questions. If someone is talking about extramarital affair, don't go in detail. कहाँ मिली आपको, कैसे मिली, किसके साथ कहाँ गए, कितनी बार गए, आपकी वाइफ को नहीं पता, आप कैसे छुपाते हैं वाइफ से? No, those are irrelevant questions to you. Physical examination is must, especially for men, without which your consultation session is incomplete. Particularly for any physical abnormalities like phimosis, unhygienic foreskin, visible curvature in penis, hard nodules, cordy, undescended testicles, hydrocele, some issue on scrotal skin cannot be diagnosed if you do not examine. And in a way, it's a therapeutic also. You can reassure the patient about his penis size only when you have examined. When you have not brought their pants down and you say, no, no, your penis is adequate and sufficient, he will say what kind of doctor he is. Without examining, he is saying I'm normal. He should also come with me to another doctor. In STDs, only examination would clinch the diagnosis. Venkatraman sir would agree. Dermatologist, no other examination needed. ये अल्सर देखा, ये यही होना है और कुछ नहीं होना है. Physical setup of the clinic, privacy. Investigation tools, pinobrachial index is almost obsolete. No one does that. Glucometer you can keep for blood sugar. So patients also say, "Haan, doctor diabetes check karta hai." Sonodoppler, which I have mentioned, first one can be used to detect the cavernosal artery, right and left. Penile color duplex Doppler can be used in a sonologist center, and NPT Regis can at a very highly center you can keep. So these are the basic investigations for erectile dysfunction only. No other investigative tools would be necessary. Educative tools, you have charts, you have slides, you have 3D models, you have animations, but avoid actual videos. Many people find out the YouTube and then they show the videos. Believe me, some patients will have an idea कि ये doctor तो blue film दिखाता है. But if you show first 4 things, they know this is educative tools, but actual videos will be considered as blue film. And develop referral system. You cannot treat each and every patient coming to you, because under the word sex, you will be coming across the gender dysphoria, you will be coming across STD, you will be coming across marital discord, non-consummation marriage, anything. But you have to have a good referral system at your disposal. General surgeon, urologist, gynecologist, psychiatrist, psychologist, and marital counselor. You are combination of everything. But when a person needs a very specific depth treatment, you might have to take help of the others. Advertisements is a major concern for most of the doctors. लोगों को पैसा पता कैसे चलेगा मैं sexologist बन गया हूँ अब. So establish yourself different from regular quack advertisers which you see here. Some of them have put a huge flex banner. Some of them have a habit of painting the walls. In particular, North India, if you saw Dr. Siddiqui, Lucknow wale, wall पे ही लिखे रहते हैं Dr. Sheikh, Nizamabad, bus stand के पीछे, शादी के बाद या पहले मिले. So you have to make your position different from this lot. You are not from those lot. Announcement within medical council guidelines. If you put some advertisement in the newspapers about your center, you follow the medical guidelines and don't cross the border. Lakshman Rekha cross nahi karna hai, otherwise you may end up in the wrong side of the law. And no big claims. 100% शर्तिया इलाज किया जाता है. 100% कोई भी नहीं कर सकता है. किसी भी faculty में medical नहीं कर सकता है. So avoid all claims. And finally, conventional advertisements like putting up notice in clinic about your sexual consultancy. Just 2 minutes, sir, I will take. Seek referrals from other colleagues. Small articles or write up in local media. Many of us are at very good mastery at it. Initiate some sexuality education program in schools and colleges. You know, once they say कि हमारे स्कूल में ये डॉक्टर आते हैं, हमको ये सिखाया, menstruation के बारे में सिखाया. Often out of 100 parents, 10 parents would be interested in you. आप क्या करते हैं, आपका clinic कहाँ है? And out of 10, 2 or 3 may turn up actually for their own problems. Get yourself invited to CME programs as speaker. This is not possible for each and every person. Only few galaxy luminaries can manage this. Discussions on some social forums and association with NGOs working in reproductive and sexual health will also give you a good support and limelight. And last but not the least, some novel ways with the use of the technology and social media. Use Facebook, Instagram, write up images, blogs, and small reels can be made. YouTube channels can be utilized. Telephone helpline. I have a very good experience of running for 19 years and answered more than 65,000 calls. It has given me a real good mileage. Online platforms, Practo, Librate can also be used judiciously, and paid promotions on search engine like Just Dial people are calling and doctor in Kolhapur, immediate Raj Sawant का नाम आता है और किसी का नाम नहीं आता है. So these things may help you. And last three things I have kept vacant. You have to fill it according to your own situation, according to your own potential, and according to your own ability. Fine, thank you.
Thank you very much, Dr. Shrish Malde.
Further questions, if you have any, during lunch and then evening function, don't disturb him. You can ask only during lunch. So we go on to the next speaker. Sir, would you introduce?
Evening session, people will be more open.
Next speaker, Sex and Law by Dr. Goda Venkatramana from Hyderabad. We invite the next speaker, Professor Goda Venkatramana. As you all know, Professor Goda Venkatramana is a sexologist, is a dermatologist, and is still practicing, is still a visiting professor in Visakhapatnam Medical College. And he is a CSEPN since more than 3 decades. That is what I know him. And together, we have done the WHO Fellowship in STDs and AIDS at Bangkok, Thailand, way back in 2008-9, where he was also awarded the WHO Fellowship. And he has many credits of doing sexological conference and dermatological conference. And last conference, which was organized in Visakhapatnam, he was actually the main mentor or the chief person, just like Srish Malde. He has done not only in Hyderabad, not only in Visakhapatnam, in most of the places he's been there.
Right, my friends. Thank you very much. Thank you, chairpersons, please. Thank you for your kind introduction. Yesterday, when I arrived here, many delegates asked, Dr. Sahab, aap sex, law and sex baat kar rahe hai. You are a doctor, how you are interested in law? Sex ko law ko ye kya link lagaya aap? Even morning also some people are asked. Then I said, time has matured now, I have to reveal the secret why I linked these two. When I was the chairman ethics committee in Andhra Pradesh Medical Council before dividing the state, one lady patient of one wife of a patient complained to the medical council against a doctor and a hospital. She filed a case. As a chairman, I have to issue notices to the doctor and to the hospital to file the counter affidavits. That so-and-so claim allegation from one patient's wife has come, stating that after your treatment, her husband is not showing interest in her. This is the allegation made against the doctor and the nursing home. Then I gave them notices to them. The counter affidavits came within 1 week, saying that hospital and doctor, same statement. Respected judge, medical council, we have not done any mistake. We have not done anything wrong to the patient. We have just corrected his eyesight. Since then, I started developing interest towards the sexology, sex and law. This is not moving by. Hello? Slide is not moving. Very poor audio visuals. You have to recap. This is not the time to be complacent. It's taking a long time. Ah. Okay, I will operate from there only. We have to give notice to him to come to the court. Why you are not operating properly? Wait a minute. बाकी पर क्लोज कर यार पूरा ये ना ये नहीं क्या नहीं वो कहीं ले रहे वो भी नहीं ये क्लोज कर पहले ये क्लोज कर अब ये ले अब ओपन कर नेक्स्ट अब आ जाता मेरे ख्याल से Right, my friends. Now I welcome you for this law and sex. I am hiding behind here and talking about law and sex. Right? Now you know pretty well that sexology is a specialized practice, a specialty of specialties. Any specialist, medical specialist who is interested and having interest to serve to the needy people can develop skills in this and he can practice. In India, as rightly said by morning speakers, still it is in the hands of the quacks. Once upon a time, we have given sex knowledge to the world. Our India is called land of Kama Sutra. But unfortunately, today we are learning and getting training from abroad, from Western countries. Now CSEPI has taken challenge this and started training our own people. And now we are training, we have trained many thousands and thousands of people. Still, this process should go on to meet the demand of 140 crore population. Lots of myths and misconceptions are around this sex and sexuality. And at the same time, unfortunately, health insurance doesn't cover these problems. That's another big drawback here. Sexual medicine is a highly vulnerable specialty. There is a lot of scope for litigations and legal implications. So people who start practicing sexology should be very careful. The number of diseases now, the classification has increased. Before World War II, all the problems of male is called impotency. All the problems of female is called frigidity. But today, because of research, because of knowledge we acquired and detailed intrications of this to human response cycle, sexual response cycle, today we have more than 25 diagnoses. As a result of the increased awareness in the public through media, people are now coming to the healthcare providers for this, seeking help. So as a result, number of patients are attending to the doctors. If the doctor is not gearing up to the needs of the patients, this will lead to patient dissatisfaction. This will lead to mistrust. This will lead to medical litigations. I am more concerned about the third one, medical litigation. Mistrust and patient dissatisfaction already is established. Once upon a time, our seniors enjoyed the position of saying, Vaidyo Narayano Hari. Now today, we are in the position of Vaidyo Narayano Hari. हमारे पास आ गए तो हरी हो गया. So we have dissatisfaction and mistrust already established. Now we are in the process of establishing medical litigations. This is more concern for this. So how a sexologist, practicing sexologist can escape this? In order to escape this, please ensure that you won't exploit the doctor-patient relationship. The fundamental thing that a practicing sexologist should observe is, should not exploit the doctor-patient relationship for personal, social, business, or sexual gain. Once we are doing this, we are giving a scope for litigations. At the same time, it is important to know that our boundaries, every specialist will have his own boundaries. If an ophthalmologist, his boundary, his erana is eye. If he is coming and checking up the scrotum, he is crossing his boundaries. Isn't it? So also a sexologist is have his own boundaries. When the person who is coming and telling that a pain in the vagina, if you are examining the breast and pressing the breast, means you are crossing the boundaries. So don't cross the boundaries, being intimate with the patient, because we sexologists, we are dealing with intimate aspect of the persons. Both physically and mentally, we should maintain, we should limit our boundaries. At the same time, we all know by this time, these terms called transference and counter-transference. When we are talking to the patients in a near zone, intimate zone, the patient may influence you or you may influence the patients. This is called transference and counter-transference, which are useful for the treatment. But romantic transference and counter-transference is detrimental to the practice, and it will land up in litigations. That's why we should be very careful. Romantic transference and counter-transference. Patient falling in love with the doctor, or doctor falling in love with the patient. This is a very dangerous trio. Is very, very difficult. We should curtail this so that we can maintain a healthy relation, doctor-patient relationship. So this is how that framework will work. Because of time constraint, I am rushing. Now tell me how a sexologist should be. To become a good sexologist in society, you should develop and exhibit professionalism. That is very, very important. This professionalism is always will solve the problem, will make you highly successful sexologist. When I say professionalism, 4 qualities should be there. Namely, excellence, humanism, accountability, and altruism. These are the minimum 4 qualities one should develop to become a successful sexologist without landing up in litigations. At the same time, as Shirish already told, empathy is the important quality a sexologist should acquire to develop a good rapport between the patient and doctor. That empathy is nothing but seeing with the eyes of the patient, listening with the ears of the patient, and feeling with the heart of the patient. So we should imagine in the patient's position and how we feel. That attitude you should develop with the patient. Then only we will become a successful doctor-patient relationship therapist. At the same time, consent is a very, very important thing, because many litigations there in the doctor coming to the medical councils, this doctor didn't take proper consent. He just asked me to sign here, to sign here. And he said, I am giving injection, sign here, but he operated on me without giving injection. So this consent is a very important thing. This consent is again classified as implied consent and informed consent. Implied consent is when the patient is coming to you, that is the consent is given. Implied, the patient knows that he is having some problem. He has identified you as the problem solver. He came to you. So for making him to sit and listen, complaint is already, consent is already there. Court will believe that even if the patient files a litigation, it will be extricated easily, because implied consent is already has come. When you are doing some procedures, say giving injection, say taking blood, say operating, then you need expressed consent. That expressed consent for the smaller problems like taking blood sample and giving injection, oral consent is sufficient. Mr. XYZ, I need your semen for examination to know whether you are fit in a fit position to become fatherhood or any infection is there. Then yes, doctor, I am ready to give. That word, yes, doctor, ready to give, oral consent is sufficient. Mr. XYZ, I have to do endoscopy for you. I have to do proctoscopy for you. I have to do penoscopy for you. I have to do other scopy for you. Then you need written consent. So that written consent should be there for that purpose only. There should not be a blanket statement. Either daskat karo, finish everything you do. Courts won't accept that. Courts will punish the hospitals and doctors. So there should be specified consent for specific procedure. So consent form should be like this. Lot of cases, the court has objected, the nursing homes given warnings also. If anybody interested to learn more about law and sex, these are the two books which I followed. I am recommending you. Happily, you can go through these books. So 4 types of consents, which I explained to you. So you have to follow based upon the need of the patient. So here I am giving the case studies of the professional secrecy. Another important quality a doctor in general, sexologist in particular, has to acquire is maintaining professional secrecy. Whatever that transpires between you and your patient, you and your client, should not be gone to third person. Let it be your secretary, let it be your other paramedical staff, let it be your wife, or let it be your husband. We have to maintain the professional secrecy. Law will give relief to the doctor, practicing doctor. He can release the information only in certain situations called privileged communication. Say, for example, here, one middle-aged lady bought his servant maid to you with ulcer on the genitalia. On examination, he found out to be herpes. When you ask the servant maid how you got when you are unmarried, the maid pleads the doctor, begs the doctor not to reveal her madam that her husband is enjoying me and got through him. So it is the communication, the maid is giving you the information, sharing the personal information. You don't have any right to reveal that, see, your servant is having an affair with your husband. You will be sued to the court. This has happened, I am telling you the case way back in 1987, where one boy came to the Chennai Apollo Hospital. I am naming it also because it is already recorded in the Supreme Court judgments. That's why I am naming it also. The boy came all the way from Kolkata, came to Chennai to give blood sample to his girlfriend's father, who is undergoing CABG, bypass operation. So many people came and gave. This boy also gave. Hospital authorities tested the blood and found HIV positive, and they refused this blood and informed to the girl's mother, saying that so-and-so blood sample we are refusing because it is HIV positive. That mother, because she knows that wife, this boy and girl are in love affair, she said, no, don't go with that fellow. That fellow is HIV positive. Don't go. Now the started the trouble between the would-be girlfriend, boyfriend, and this fellow filed a case in the Chennai court. And because since this type of complaint legal litigation is the first time in India, it referred to the Supreme Court. Supreme Court constituted a special committee and inquired about this. Then 4 more cases came after this. All inquired as a bunch case and declared that revealing personal information here in the interest of the beneficiary, who is the father-in-law, for the interest of the beneficiary, hospital has revealed the thing. Here they have not done any mistake. Here the doctor cannot be found guilty. It's a privileged communication because the doctors in the hospital has revealed in the interest of the beneficiary. So there are 4 situations like that where you can reveal the personal history. Otherwise, revealing to the mother here and there, you will be finished. You will be put under litigations. Another 3 cases, I am skipping it because of the time constraints. Before the chairpersons warn me, I have to close this. So other indications are when the patient is minor, when the patient is a convicted prisoner, when the judge is asking the court of law, tell me what happened, what exactly the case history, or when the patient himself, his health is at risk. Another thing is when the society at risk because of the patient's behavior. Your patient is having fits, epilepsy, and he is on treatment for you, begging you not to reveal to this family members, anybody, because if you tell, then they will stop me working. If I won't work, my family will be at crossroads. But if he is not using drugs, as long as he is using the drugs and he is not throwing any fit, it's fine. Nothing will happen. Once he is not using drugs, then if he gets fits while he is driving, lot of lives will be at stake. So you have to reveal, and the law will help you, will bail you out under the privileged communication, because in the interest of the society. So the sexologist must disengage from their own belief system. A doctor's sexual advances towards the patients are never okay. Even if it is consensual, we should be very careful, because our Hippocratic oath clearly shows that abstain from all intentional wrongdoing, harm, and especially from abusing the bodies of the man and woman. And it clearly says, whatever house you may visit, you will come for the benefit of the sick, remaining free of all intentional injustice, of all mischief, in particular sexual relations with both male and female persons, are should very much condemned. We should not do this. We should be very careful. Right? These are all the things about the same Indian law. Preventable. There is a beautiful study, I'm focusing you for 1 minute, where crossing the sexual boundaries by the doctors is, in the world, is around 7%. In India, it is around 6%. These are all the various issues that are there, the doctors are doing. We should be very careful. Otherwise, this is the study. 817 disciplined physicians are being put under litigations. Inappropriate behavior is the major culprit there. We should be very careful. So this is one, physical relationship. And at the same time, we should be very careful. Our profession is governed by legislation, code of ethics, and etiquette. So every sexologist should be thorough with laws that are governing our sexology profession: IPC, CRPC, Law of Torts, and the Medical Council Act. So the common laws where will be implicated is 375, and at the same 354 and 355. These are all the punishments what we get when you go there. So this is the law book which I referred, and I'm telling you, I'm following it also. So here the complaints made to me and to other medical councils which I collected. Dear sir, this doctor uses a very offensive, unparliamentary language while taking sexual history. Please take appropriate action. This is another one. Another one, when I expressed my sexual dissatisfaction with my husband, this doctor proposed me for his sexual satisfaction. A female 32 alleges that his sexologist is pressing her breast in the pre-test of examining, and his behavior is highly improper. A sexologist is a sex maniac. Please take appropriate penal action. When myself with my wife consulted her for professional help, here the female sexologist, this is from again Maharashtra. She, while examining me, started masturbating me, and I ejaculated immediately. She declared with my wife that my nerves are weak and cannot satisfy my wife. She promised my wife that she will train me how to satisfy my wife. See, we are grossly crossing the boundaries. We, myself, my wife, went for the counseling to the sexologist. His behavior is highly unethical, more commercial, all the more encouraging extramarital affairs. He is asking my wife, if you are not happy with him, be happy with someone. One young male of 28 years says, sir, just married 3 months. I am ejaculating early. My wife took me to a sexologist. He said on the face of my wife, this case takes a long time, more expensive. My wife asked divorce. Now I am a divorcee. When I complained, discomfort, burning pain in my vulva, this doctor examining my breast. See here. I asked my husband, this also I got in my own practice. When I asked that to allow my husband to be at my side, when you are examining, this doctor refuses and prefers to examine me alone. I am afraid of this and walked out in his clinic. This also happened to me when in the early days of my practice, when the patient said, doctor, please call my husband. Then I said, yes, ma, I will call you, but tell me anything from my side, any wrong thing I did. Did I exceed in my boundaries? Did I talk anything rubbish? Did I do anything? No, doctor, it is not the case. If you won't allow my husband inside, your secretary will be spoiled outside. Right? So patience, delicacy, secrecy are the 3 things that one should be there. We don't interrupt with the MSM activities. Be patient enough. Don't say that I will treat you, I will convert into normal. All these things court is taking very seriously. Supreme Court now it has abolished this. Even the Chennai Madurai bench also given statement, punish the doctors who are promising MSM treatments. So don't do that. Section 377 is abolished. Now these are the 2 advocate twins who fought tooth and nail and could succeed in abolishing this, namely Menaka Guruswamy and Arundhati Kadju. Arundhati Kadju is the relative of Markandeya Kadju, former CJ of Supreme Court. So this is the Chennai bench judgment. Hence, my friends, these are all the legal provisions because already there is a pressing need, outraging the modesty of the female and sexual harassment and this what you call peeping toms and stalking. All these things, these are all the various sections that come into picture. So that will solve. We should be very, very careful. The only thing that I can tell you is because of time constraints, always when you are talking to the sexologist, justify yourself that you have taken informed consent and your talk and your examination, your history taking should be necessary for that complaint. And every action you have done with a good faith. These 3 things, if you follow, then courts will be with you. There won't be any litigations and you will develop good practice and you will become a successful practitioner. With this last slide I'm telling is whatever transfers between you and the patient is 7% in the form of spoken words, 38% in the form of voice quality, but 55% is our body language. So mind this, behave properly so that don't cross your boundaries. Once you cross your boundaries, before female, male is nowhere. So take care. Thank you. Thank you for your patient listening.
Thank you very much. Sir, it was really very refreshing, educative, and the way you conducted it is so well. I'm told that next
Sir.
lecture, Dr. Rajit, I suppose is not here.
Yes, sir.
The lecture is cancelled.
Yes.
Aging men and sex, that men never age, but still, because he's not.
Yes.
So
Now I would ask the chair, due to time constraints, we will go for the question and answer session in the evening time. I would ask the chairperson to facilitate Dr. G. Venkatramana sir for his excellent legally excellent, brilliant talk. Now I would request Dr. Brahma Bhatt sir to felicitate our esteemed chairpersons. One minute. Sir, please continue as chairpersons for the. आप है ना? हाँ. Sir, just a minute. फेलिसिटेट करना था ना आपका, आ जाओ. Shirish is coming. ये material हल पहले प्ले करना फिर मेरा टॉक प्ले करना. हाँ हाँ. Now I would request Dr. Sharad Gaur and Dr. K.N. Gehlot to grace the dais. 1 minute. I would request Dr. Brambhat sir to felicitate our earlier speaker, Dr. Shirish Malde. हाँ ये मेरा इंट्रोडक्शन है. अरे है ना उसमें. अरे नहीं रे बाबा, खोलिए मेरा पेन ड्राइव खोल. फिर ये हाँ, यही खोलना है सर. Now I would request Dr. Sharad Gaur and Dr. K.N. Gehlot to the dais for chairing the next sessions.
Now I invite Dr. This topic is recreational drugs and sex. Dr. Brahma, MBS, MD, and Associate Professor, GMC, Hostel Bombay, Vice Chairman, Secretary Committee, since member scientist, and research center, and many more. He is very active member of society, and he is very designated.
Thank you, Chairperson, for the kind words. Now, today's topic is recreational drugs. Now, recreational drugs, as this was in great news because of Aryan Khan and the cases associated with it. Of late, I have been getting these kind of cases, people who are on high taking drugs for enhancing their sexual performance. So while I read the literature for this particular topic, I found that even if a different drug is tried, a recreational drug is tried every single day, there are more than 365 recreational drugs for the entire year. And it's a vast subject. Probably a conference can be arranged on this particular topic. Now, Vivek, hello. कुछ नहीं हो रहा है बॉस. On their own, sex and drugs are cultural issues. Excuse me. हाँ, हो रहा है. Sex and drugs are two taboo topics. Combining them only adds to the reluctance to talk about them. Understanding how sex and drugs are connected is the key to our understanding of what is called as chemsex and their deviant behavior. Humans have intentionally used drugs to facilitate and enhance their sexual experiences from millennia. Right from the Indic civilization, where ganja was used to enhance sexual performance, to the Egyptian civilization, where they used extracts from the blue lotus flower, to the Chinese civilization, where they used mercury and some extracts from the poppy seeds. More recently, in 1960s, psychedelic advocate Timothy Leary stated, LSD is the most powerful aphrodisiac ever created. Now, this is the theme of this particular topic. And ultimately, for this pleasure, humans have traversed to great extent. One recent study reveals a diverse group of people across a range of sexual and gender identity who use drugs to enhance sex with equally diverse motivations and experiences as follows. For some, it was improving emotional connection. Desire was heightened in some cases, and few bodily sensations were increased. In many, sex enhanced the experience of drugs as well as drugs enhancing the sexual experience. So it is kind of reciprocal, sex enhancing experience with drugs and drugs enhancing the sexual experience. There are limitations of thinking about the sexual enhancement is purely physical terms by highlighting the ways that drugs can enhance emotional aspects of sex. So by definition, as it's common practice in medical academics to define any particular thing, use of a psychoactive drug to induce or altered state of consciousness, either for pleasure or some other casual purpose or pastime, by modifying perceptions, feelings, and emotions of the user. Recreational drug enters the user's body, it induces an intoxicating effect. They are divided into three to five categories: depressants, stimulants, hallucinogens, euphoriants, and inhalants. Now, the etiology, there is no agreement around any one single cause. As per biophysiopsychosocial model, any number of these factors are likely to influence an individual's drug use, as they are not mutually exclusive. Regardless of genetics, mental health, or traumatic experiences, social factors play a large role in exposure to availability of certain types of drugs and patterns of drug use. Now, these are the most common contributory factors: genetics, personality types, psychological issues, self-medication, family issues, and attachment issues. Now, you can see the most commonly used drugs for enhancing the sexual experience. The most common is what we call tobacco, alcohol, caffeine, followed by opioids like heroin, then cocaine, and rave party drugs like LSD and ketamine. Now, substances which are commonly used. Now, most common addiction is, we all are aware, tobacco smoking, followed by alcohol, then caffeine, opioids or you commonly in our parlance is heroin. Then you have cannabis, cocaine, amphetamines, and the list is endless. Now, coming to tobacco smoking, the causal link between cigarette smoking and ED involves pathophysiological, biochemical, and chemical mechanisms. Smoking leads to vascular endothelial injury via the nitric oxide activity and reduced vasodilatation. There is an imbalance of oxidative and antioxidative mechanisms, increasing the production of pro-inflammatory cytokines like interleukin 1, 6, and TNF alpha. Clinically, there is vasospasm, which leads to constriction of the penile artery, therefore compromising the vascular flow to the penis. Low testosterone, there is increased sympathetic tone. Low testosterone levels may be associated with atherosclerosis and erectile dysfunction. Passive cigarette smoking is also known to lead to ED. This is a common sight outside the colleges of Mumbai. So smoking is the new in thing, even among women. So the thing is that to have good sex life, one has to quit smoking, and they have to decide that the last cigarette was smoked today. Now coming to alcohol, there are divergent views and research about effect of alcohol on sex. Definitely, it's known that alcohol is a CNS depressant, facilitation of sexual behavior and arousal due to lowered inhibitions, clear evidence of dose-dependent negative effects on potency and sexual capacity, interferes with sexual response due to metabolic changes as it alters nitric oxide synthesis. Similarly, certain contradictions have been observed in same studies regarding the influence of alcohol consumption on sexuality. This study shows that alcohol consumption improves sexual function, arousal, and orgasm. So, as I said earlier, there are contradictory evidences as far as consumption of alcohol and their effect on sex is concerned. Now, coming to psychological effects of alcohol, perpetrator self-expectations, stereotypes about drinking alcohol as a sexual signal. Victim, there are expectations, perpetrators, selection of the victim. That during the assault, the pharmacological effects of alcohol come into picture. Cognitive impairment, heightened aggression. Victim, cognitive impairment, bias risk assessment, and motor impairment. Explanations: for perpetrator, alcohol as a post hoc excuse. For victim, it is blamed for losing control. Now, reported improvements in sexual pleasure, arousal, and sexual behavior. The study focused on a population between the ages of 18 to 30, where the prevalence of erectile dysfunction is less. So, again, the effect of alcohol as far as sex is concerned depends on the age of the person. As far as women are concerned, some studies reported no significant difference in sexual function among them, and some research indicates a positive relationship between alcohol consumption and sexual function. Now, alcohol is like this beautiful woman, the lady. It's very appealing to consume alcohol, but the end effect, what overall research suggests, is the second picture. Now, coming to caffeine, moderate caffeine intake appears to have a positive effect and does not seem to cause erectile dysfunction. The study found that drinking 2 or 3 cups of coffee per day can lower the risk of developing erectile dysfunction, and relaxing the arteries and smooth muscle in penis, allowing more blood flow and improving erectile functioning of the penis. Excess caffeine can cause anxiety, sleep disruption, headaches, and palpitation. All these 4 are reasons for, are symptomatic reasons for erectile dysfunction. Research on caffeine intake and its effect on men's fertility is mixed. In addition to boosting energy levels, caffeine may increase testosterone levels in men. Research shows that men who regularly consume caffeinated coffee have higher levels of testosterone than those who don't consume it. So that is why we have this chain of cafes like Cafe Coffee Day and everything. Ultimately, the idea, the marketing idea is to make it more appealing in by saying that your sexual performance is increased. Okay. Frozen. So all in all, caffeine has a positive effect as far as sex is concerned, but in high doses, because of induction of palpitations, anxious behavior, they can definitely cause difficulty in arousal. Opioids and sex. In 2016, Now, before going into the details of opioids, let me tell you, opioid as a group has the most diverse effect on sex because of the diverse nature of these opioids. Opioids who are agonists, they will have a different effect. Partial agonist will have different effect. Agonist, antagonist will have different effect. Antagonists will have different effect as far as sex is concerned. So as a prototype, I have considered heroin over here. The United States FDA issued a warning regarding severe safety issues associated with opioid pain medications. The reported that long-term use of opioids may be associated with decreased sex hormone levels, symptoms such as reduced interest in sex, impotence, and infertility. Opioids may decrease sexual function because they affect the level of hormones in the hypothalamo-pituitary gonadal axis. Because of their effect on GnRH, opioids inhibit the GnRH, leading to decreased production of luteinizing hormones, which in turn affect the production of testosterone. Having low testosterone causes depression and sexual dysfunction in both men and women. So one of the most commonly used opioid is codeine in cough syrup, and it is one of the most cheapest and easily available addictive substance in the market because it is easily available from pharmacies. Now coming to cannabis, it has been very old as far as Indian civilization is concerned. It is one of the first drug to be used as a sexual enhancers. Young people who use cannabis frequently, irrespective of gender, have better sexual function, heightened perception, time distortions, relaxation, increased inhibition. Now, cannabis definitely has some clearly defined gender-dependent effects. In men, it has a peripheral antagonist effect on sexual function, erectile function by stimulating specific receptors in cavernous tissue. Now, recent evidence has defined play a role of cannabinoid receptors in the penile tissue. Frequent cannabis use renders it difficult to reach orgasm. A study found the connection between increased cannabis use and increased sexual function, as well as higher sexual satisfaction and decreased prevalence of erectile dysfunction. A previous study found that cannabis users have high sexual frequency than non-users, as well as a higher score on the sexual health inventory and serum testosterone, among others. Now, this is how the cannabis effect on the brain functioning, inducing delusions as well as hallucinations. In women who reported more cannabis use, had higher overall sexual satisfaction, higher sexual function scores, desire, arousal, as well as orgasm. Researchers stated that majority of women who use marijuana before sex reported positive sexual effects. Chronic use of cannabis mildly modulates seminal and hormonal parameters. Higher level of FSH indicates infertility in men. Now, coming to cocaine and sex, euphoria, heightened awareness, increased sensory stimulation are just some of the reasons why people believe sex on cocaine is more pleasurable. Cocaine often leads to increased energy and confidence. Cocaine has gained some prominence because of Aryan Khan was arrested for this particular drug. Sex drive from cocaine use, a person is more likely to engage in sexual activity multiple times. Individuals reported that sex on cocaine lasts longer and orgasms are more intense. Impulsivity is an effect of cocaine in relation to sexual activity. Men are less likely to use a condom. High levels of cocaine over a period of time may result in person being unable to satisfy the sexual desire. In men, it has also been linked to low sperm count or priapism as well as prolonged erection. Obtaining consent or assuming consent is illegal under the influence of cocaine or any of these agents, as earlier described by Dr. Venkatramana sir. Now, this is how cocaine is taken. Usual way is by snorting. The other way is by injecting IV. Now, as far as effect of cocaine on women, the cocaine helps in orgasms, heighten and prolongs them, initially somewhat accurate, but orgasms on cocaine may be harder to come by for the long-term users. Women who engage in sex while being high on cocaine are at the risk of sexually transmitted infections, unsafe sex, and unwanted pregnancies. They can change a woman's menstrual cycle as well as stop ovulation and damage the fallopian tubes. This can result into sterility. Coming to amphetamines and sex, methamphetamine is a psychostimulant that is widely abused and linked to serious public health problems globally. It enhances the sexual confidence, diminishes the sexual inhibitions, increase sexual desire, arousal, pleasure, and delay orgasms in both humans and animals. So this is the a gradual progression of experiences with methamphetamine, sexual as well as neural, and then both. Some individuals have reported that sexual for their amphetamine use. And coming to the transition from voluntary drug taking in compulsive drug taking may be the result of dynamic shifts from the ventral to dorsal striatal environment. Now, most important as far as these agents are concerned, LSD, it is the most powerful aphrodisiac ever invented by humans. According to Annie Sprinkler, a well-known pornographic actress, sex educator, and writer, she recalled her experiences with alternate realities, new dimensions, and other ways of seeing and feeling, which meaningfully informed her transformation into an sexual adult after taking LSD. In his book, Peter Hannis suggested that with LSD, sexual love may be transformed into a type of worship in which the partners are for each other, incarnations of the divine. The effects of LSD are unpredictable, dependent on amount taken, the person's personality, mood, expectation, and the situation in the drug is used. Effects are usually felt within 30 to 40 minutes. The LSD experience is commonly known as trip and can last up to 12 hours. So people who are indulging in binge sex, orgies, group sex, they are probably doing it on LSD. So this is how you get visuals after LSD. And this is the reason I have this particular type of goggles. So the reality gets blurred. You are in a different world. Probably you become an alien and reach Mars, Pluto, or whatever. So usually this is how things are with LSD. So there is changes in sensations and feelings. The person may feel several different emotions at the same time or rapidly swing from one emotion to another emotion. Serious psychiatric conditions can develop after even one use of LSD, and that can last a lifetime. So LSD is a proverbial double-edged sword. The cause of these effects is not known. The conditions include drug-induced psychosis, hallucination, persisting perception disorder. Sex on acid or any psychedelic for that matter can be a really interesting experience for those who want to experiment, but be careful. It can last a lifetime because colors and sensations are more vivid. Since time moves slower, the sex can seem to last for hours or even for days. You might even get to play out some sort of your sexual fantasies. Now coming to my last slide, the crux of the matter of this particular talk is notwithstanding the benefits reported of recreational drug consumption, such drugs is associated with risky sexual behavior such as unprotected sex, appearance of sexually transmitted infections leading to a careless and unsafe sexual encounter. These high-risk attitudes are associated with increased relaxation, euphoria, disinhibition, decreased self-control and decreased risk perception caused by psychoactive substances, which cause users to be less cautious and to forget the importance of safe sex. For the younger population, alcohol and tobacco consumption is closely related to nighttime recreational environments, which are key element for socialization, and where the consumption of different substances can lead to altered decision making regarding sexual relations associated with an increasing in engaging risky sexual behaviors. Sorry for the thick font I have used, because I wanted to emphasize this particular effect of drugs on our thinking, clouding, as well as sexual behavior. Thank you. Yes. Generally, as well as per what I have come across the literature, long-term consumption of alcohol definitely reduces the performance by decreasing the androgens, so thereby affecting the libido as well as the quality of erections long term.
Secretary is right and she very talented. Yeah. I am ready. We do not provide any instruction. Keep going to talk about non-judgmental.
So slide change. Slide changer. No, it's okay. It's okay. Then. Yeah, okay. Good afternoon, everybody. It is going to be the lunch time. I hope I can keep you awake to listen to that, a very important topic. And I think most of the ladies, women doctors are in the other hall, and men are here. most of the things, and from the morning you were listening about the male problems, and now it is the combined problem, a very important issue, because for so many people, when we take that the first sexual intercourse starts in the first night, the night of nights or the golden night, where both the husband and wife will have very high expectations to start their sexual life, and first night can be the last night also for so many. It can be utter disappointment. Sexuality is all about the quality of life, health, harmony, and happiness for the couple. So anything that disturbs, as you all know, sex is a complicated thing. It is not a straightforward thing. Both the physical, mental, psychological issues, hormones, nerves, blood vessels, the culture, interpersonal relationship, and so many factors are acting upon that. So any disturbance in any of these things can upset the sexual functioning and can lead to the disappointment. The problem can be in the female, the problem can be in the male, and most of the time, because of the unrealistic expectations, what is shown in the movies or what is shown in the serials or magazines, so there is an unrealistic expectation and exaggerated projection of the first night or the first consummation. Of course, today the premarital relationship is a reality, and so many times the first night may not be after marriage, and there are alternatives which have come for the marriage, like live-in relationship, single parenthood, single with the sexual relationship. All those things have come up. So we have to know what is the reason for non-consummation of marriage, whether it is in the man or the woman. With so much of rituals and the exhaustion and the tiredness and the late night, so most of the time, first night, the couple may not be able to start their sexual relationship also. But if there is a proper premarital counseling, all these issues can be tackled, and there can be a proper awareness. Even the failure is common, and you should not think that a first night failure or if the first intercourse is not successful, that is not end of the road or end of the day. So coming to that, so usually after marriage, intercourse and sexual activity is naturally and mutually expected in both the spouses. Unconsummated marriage means that couple never have sexual relationship. But studies also have shown that sometimes not only the intercourse cannot be consummated at the first try, but it could also be delayed for years and even would never happen. This is called unconsummated marriage. I have had a couple who had not consummated, they had come for an infertility treatment at the age of wife at the age of 42 years and the husband at the age of 48 years. And when I took the history, they had not consummated the marriage, but still they were not even aware that they had not consummated the marriage. That is the longest period of non-consummation which I had come across. So since one of the main goals of the marriage is having satisfying marital relations, encountering problems in this dimension could have wide unpleasant effects on all the aspects of individual's life. On the other hand, due to cultural and social limitations, most couples would feel confused when seeking for treatment. This is another important problem. Even though they have not been able to consummate, have got trouble in consummating the marriage, so they don't even know whether there is a help available there. In many traditions and statutes of civil or religious law, the consummation of marriage, often called simply consummation, is the first officially credited act of sexual intercourse between two people, either following their marriage to each other or after a short or prolonged romantic or sexual attraction. The definition of consummation usually refers to penile vaginal sexual penetration. The religious, cultural, or legal significance of consummation may arise from theories of marriage or as having the purpose of producing legally recognized descendants of the partners or of providing sanction to their sexual acts together or both. And its absence may amount to treating a marriage ceremony as falling short of completing the state of being married, or as creating a marriage which may later be repudiated. The importance of consummation has led to the development of various wedding rituals. You all know the decoration of the bedroom, and it should be pleasing to all senses. That's why we call it as more sensual and sexual. So it has to please. You have the music, you have the things to eat, and you have the smell, aroma, and that is how the bedroom is decorated so that it can be a stimulant for the couple to start their sexual life. It's not moving. So different physical, mental, social, and cultural factors are effective in occurrence of this disorder. It should be considered as multi-dimensional issue. Unconsummated marriage mainly is due to vaginismus in the woman or premature ejaculation in the man. These are the commonest causes of, so next to ignorance or inadequate knowledge. No, it's not moving. Not moving. Yeah. So the non-consummation of marriage, there are various reasons for it. It can be in the female or it can be in the male, because most of the time, because people understand that everything the man has to start, man has to initiate all the sexual act, so that there is no problem with the female. It can only be the problem with the male. If the first night it is not consummated, the female or the relatives of female or the wife will create a big problem, and they make it a big issue and a scene, creating that this man is impotent, even though there is if there is a non-consummation because of vaginismus, but still they expect the man to do the first intercourse, and they think the man is impotent, and they make a big issue out of it, and the man remains remains with a sexual dysfunction throughout his life most of the time. So this can be lack of knowledge, inadequate knowledge, developmental problems which are very important, like absence of vagina or tight hymen, rigid hymen, and other developmental problems, the narrow intritus, and religious orthodoxy. So many times they think out until marriage, sex is considered a taboo, and very religiously they will be avoiding all the knowledge and the activity. And suddenly after marriage, sex assumes a big importance, and so they're supposed to know everything about sexual relationship. So negative feelings about the marriage, painful intercourse, vaginismus due to fear and phobia of sex, or bleeding and pain. The commonest myth is about the virginity myth, for which for the first intercourse, the girl has to bleed, otherwise she is not a virgin. That creates so much of an anxiety for a woman. So many times she may not be able to cooperate, and even she can end up having vaginismus. And the child sexual abuse, if there is a history, that can be one of the reasons for that. Next. So in males, again, the lack of knowledge I have had that because I come from Bangalore, where I have highly educated, highly placed ITBT people. After reaching one particular stage, throughout life, they will have only the study, getting first rank and highest marks, and then go to IIMs, IITs, and get a highest position. So the general life skills will not be there. And most of the time I have seen the lack of knowledge itself is the main cause for the not consummating the marriage. So when they come for infertility treatment after 5 years, 10 years, because of the social pressure to have a child, then only so many of these things will come to light. So these are all the various reasons: the tight foreskin of the phimosis, erectile dysfunction, premature ejaculation, performance anxiety, painful intercourse. And in addition to all these things, there can be other social factors or the cultural factors, the mutual dislike, fear, anxiety, lack of privacy, dispute between both the families. Most of the time, for some reason or the other, there will be a quarrel between the two families. This is not correct, that is not right, I did not get what I wanted, and that one particular person did not show respect. All these things can affect the bride and the groom, and then that can end up with non-consummation of marriage because of the hatredness, lack of time, exhaustion, etc. So they cannot the other things which usually happens is that the man may be unable to find the vaginal opening. The wife may also be having anxiety, and she is also shy to participate in the sexual relationship, and erect penis cannot be inserted. Erection of the penis cannot be maintained. Woman sleeps with her legs stretched and separated in a wrong position, so that the man just lies upon her and it's unable to penetrate. Glance of the penis is oversensitive, leading to the premature ejaculation, or there is inability to ejaculate during intercourse, hence unable to father a child. The presence of the couple together at the counseling center for treatment is necessary, and husbands have an essential role in the treatment of this disorder. For the non-consummation, so many times what happens, the man, this is my experience and everyone's experience also. So many times the husband comes and tells, doctor, we are unable to have sexual intercourse. I have got erectile dysfunction. Please treat me. So when I say that, no, I have to see the wife also, the couple has to come together, then only I can find out what is the reason. No, everything is okay with her, and only it is the problem with me. And if the wife also comes, she tells, no, everything is normal with me. You treat my husband. He is the one who has got the problem. But somehow coaxing her, doing an examination, if you see, that girl will be having severe vaginismus. So the erectile dysfunction is because this is a secondary dysfunction which has developed because of the vaginismus. So it is a very common scenario because both of them do not come together to a single doctor. The wife goes to the gynecologist and the husband goes to urologist or the surgeon or someone. So what happens? The problem remains like that even after taking treatment for 5 years, 10 years. Husband will be eating so much of sildenafil tablets and wife will be using so much of lubricants. Ultimately, the problem remains. So this is very important to see the couple together. So this can also be a cause for annulment of marriage if there is non-consummation. So what I concentrate is mainly on the vaginismus, which is the commonest thing and sometimes difficult to understand, difficult to treat, and the problem remains for many years unless it is treated properly. So just I will concentrate more on this vaginismus as a cause for non-consummation of marriage. We call it as the vaginal blink, like how in front of your eyes, if you just want to bring your eyes or some object comes, suddenly you blink. That is to protect your eyes. In a similar way, any thought of it, or even the husband comes closer, or any touch of the vagina, suddenly the vagina contracts. That's why that word I have used. So this is the vaginismus, how it is binding the woman. And today, even to date, the involuntary muscle spasm remains the core element of the definition of vaginismus suggested by American College. So the International Classification of Disease, ICD-10, it classifies it as a pain disorder or the sexual dysfunction comprised of a spasm of the pelvic floor muscles that surround the vagina, causing the occlusion of the vaginal opening, with penile entry being either impossible or painful. There are three things involved. One is the fear, next is the pain, and the other one is the spasm. So this is a combination of fear, pain, and spasm which you have to concentrate. So this is the current definition of this. Vaginismus is currently classified as in DSM-5. Earlier, there was separate classification like vaginismus and dyspareunia. Now they have combined in DSM-5, and this is known as genital pain, pelvic pain penetration disorder, where both of them have been combined. So this is a recurrent or persistent involuntary spasm of the musculature of the outer third of the vagina that interferes with sexual intercourse. So duration has to be 6 months if you want to call it as, or about the 75% of the time encounters, they should be problem. So this is a very common thing worldwide, 1 to 7%, 7%, and in the clinical settings, it is 5 to 17%. The classification again can be like any other sexual dysfunction. It can be primary, secondary, it can be global, or just a situational. These are all different classification. And I don't want to take too much time. I'll just go a little faster. So the vaginismus can be mild with a mild discomfort and burning. It can be moderate with pain and severe discomfort, or it can be severe where coitus and per vaginal examination will be impossible. So the different grades have been described: first degree, second degree, third degree, and fourth degree, where you can see that initially just complaining and telling that there is discomfort, pain, and in the severe forms of the vagina, they don't even allow the doctor to go near that. They close the thighs, elevate the buttocks, and sometimes they push the doctor also. So grade 5, the PASIC included this degree in which patient experiences sweating, palpitation, hyperventilation, shaking, nausea, vomiting, giddiness. She may even jump off the table or attack the doctor. I have come across such severe cases of vaginismus where they just go into clonic contractions of the thighs with severe vaginismus. So this is a conditioned response, and provoking stimulus can be previous experience of pain, fantasy of pain, or fear of penetration. It can be just in the mind, just a fear, or there's some experience or some abuse. And most of the time, the vaginismus is caused by bad advices. This is what I say. Most of the time where I come across vaginismus, it is because of the bad advices given by the friends or the media or whatever, wherever they have read. For some, it goes so deep into the mind, a deep-seated fear will result in the vaginismus. Most of the time, it is caused by bad advices and also the myth that first intercourse will cause pain and bleeding. Libido is usually unaffected. They have got a good desire, but unable to perform when it comes to the penetration and the actual intercourse. This is not possible. With vaginismus, the mind and body develop a conditioned response against penetration. The body has learned to expect or anticipate pain upon penetration, so that the powerful PC muscle or the pelvic floor pubococcygeus muscle flinches or contracts to protect against the potential of intercourse pain. This can be equated to blinking of one's eyes, as I explained, and mincing when an object is hurled towards the person. So it is not something a woman thinks about doing. It just happens. It is not intentional or voluntary. That has to be known. She may be, because the husband thinks she may not be loving me, she doesn't like me, she has married against the wishes. That's why she is not allowing the intercourse. So this is an involuntary thing, not that she is doing it intentionally. So this, although this can look like very upsetting and embarrassing, it is absolutely treatable. There is 100% cure rate if you treat the person properly. So it is a common cause of ongoing sexual pain and also the primary cause of non-consummated marriage. So etiology, various things which I described. There can be some amount of fear of other things also, like anxiety, guilt, fear of pregnancy, STD, intimacy, and also the vulnerability and discovery and punishment, fear of vagina being small or penis being too large, self-count, body image problems. So many times, if they're suffering from some hormone disturbance or very obese, and they think they have got a body image problem, the husband may not like my body, and I may look ugly, and he may not like me or love me. So all those body image problems also will come into picture. And the sexual trauma to various reasons, rape, incest, child sex abuse. And there can be the misinformation, ignorance, fear of pain, and some organic pathology. If there is definitely a developmental problem or any pathology there in that region, so that also can lead to this vaginismus. So how they present? Mainly by the history. As per the degree of vaginismus, there can be minor discomfort, burning or tightness, or there can be a serious problem, penetration being impossible, repeated excuses for pelvic examination. So many times when they keep on coming to the doctor for treatment, and you ask them to go and lie down on the table that I want to do the examination, they start giving all possible these excuses. I am not clean, I have not washed myself, I have not shaved myself. So next time, next time. So they don't want to get examined. So there is a difficulty of examination, refusal to unrobe, repeated excuses for coitus. Not today, today is Monday, Tuesday, or I'm doing puja and some other day and so holiday, I'm not in mood, all that. They can go on giving this. And main symptom is about this non-consummation of marriage. And infertility. One is non-consummation, next is the most important presentation is the infertility. Any lady who comes for infertility or any couple, please rule out the non-consummation of marriage so that once you treat that, automatically they will conceive within 3 months and come back to you. And various male sexual dysfunction also can lead to this form of this vaginismus. Repeatedly, when the man is having this, she loses interest and they can have. And if they have having some hostility, discord or frustration and rejection, so it can end up in divorce. So this can result in marital disharmony, disturbed interpersonal relationship, faulty sexual intercourse, guilt feelings, and also secondary erectile dysfunction in the man. So this is by history and by examination and closing of thighs, spasm of the adductor muscles of thighs, arching of the back, squeezing of vaginal muscles, and jumping off the table. And so you have to do a proper assessment, examination of the external genitalia, gentle pelvic examination. So many times I have seen the forcible pelvic examination done by some doctor, and they say, I will never go to any doctor anytime. So when I asked the husband to bring the wife, no doctor, 2-3 gynecologists she had been to that, and there was so much of pain. She says she refuses to come to any doctor. I don't know how to bring her to the examination. So examination of woman becomes extremely important, a pelvic examination, and we had to rule out the other causes like dyspareunia, but this there is a differential diagnosis, a dyspareunia, painful intercourse, but though they may look similar, but they are different, and vestibulodynia, a severe pain upon touching the vaginal entry within the vulvar vestibule due to various reasons. Vulvodynia and vestibulodynia has to be ruled out. And the cycle of vaginismus, first there is a fear of vaginal penetration, there is an involuntary muscle spasm which can lead to pain, later to humiliation, anxiety and distress, leading to infertility. So there is a relationship breakdown and also avoidance of intercourse and gynec examination. So these are the three components which I was telling: fear, pain and muscle spasm. And the treatment, when you come to that, there is still the controversy over the treatment of choice for vaginismus. Vaginismus is a phobic reaction to an excessive fear of pain. It was one of the first to recommend psychotherapy, and Masterson Johnson has got his own behaviorally oriented sex therapy, which included vaginal dilatation. So that is sensate focused therapy, slowly understanding their own body step by step. And the pelvic examination is the most important thing. You can use it to diagnose and also give her the suggestion, the sexuality education, tell about the normal process of intercourse and find out the problem. So give the reassurance that it can be treated and utilize that opportunity for both diagnosis and treatment. So the current treatments which are available for vaginismus include the 4 main categories. The pelvic floor physiotherapy, that is by how to relax the abdominal muscles, thigh muscles, and also pelvic floor muscles. The Kegels exercises become most important. The deep breathing exercises where she can relax her abdominal muscles, thigh muscles, and Kegels exercise to know, to get the muscles under control. When she is contracting, when she is relaxing, she can understand. And some pharmacological treatments in the form of using lubricating gels and sedations, and the general psychotherapy in some cases, and cognitive behavior therapy, which is, so these are all the dilators which are available, graded dilators. And first, the finger is the best dilator to the woman or the husband, and varied size, for a common man, varied sizes candles covered with condoms can be used as different graded dilators that can be done. First, ask her to relax the muscles. Tell her to touch her genitalia because they are very uncomfortable to touch the genitalia itself. Let her become first comfortable touching her genitalia. Then slowly, using the lubricant, insert one finger inside the vagina. When she is comfortable, start inserting 2 fingers. Then if it is possible, 2 or 3 fingers. When she is completely relaxed and comfortable for the genital touch, then you have to tell them to go ahead with the intercourse. Before that, they have to do all this. She should understand her body, how she can relax. Start with all the sensate focus, understanding the body, and to know how she can be excited, how she can be aroused, because both the husband wife taking part in all the foreplay, everything, so that without fear she will participate in foreplay and other things. So then she will reach the final stage. By that time she will be ready for the intercourse. So these are the pelvic floor exercises, graded dilators, and these are all described. Local anesthetics, I don't like this local anesthetic gel or local anesthetic injection, whatever it is, because the woman has to understand the sensations. We don't want to blunt the sensation. She should understand the sensation and also the enjoy the genital sensations. So these are all the things which are described, and muscle relaxants and which can relax the vagina, but in the long run. But now the botulinum injection has come in a big way. Many people are using that. Some anxiolytic medications like diazepam, and in many places they are doing the dilatation under anesthesia and also with the botulinum injection, which can relax the muscle. But I can simple education, giving them to how they can be comfortable with that, relaxing the muscles and the dilators. These are the simple treatment I have seen. I am able to treat almost all the patients of vaginismus. So it becomes the exercise, education, and therapy. Remove the guilt, shame, or embarrassment from her. So primary vaginismus and secondary vaginismus. Secondary vaginismus, after a period of not normal intercourse, it can start after some labor or the rape or during menopause. So depending on the situation, you have to treat the condition of secondary therapy. So vaginal examination is a crucial part of therapy. It provides an opportunity to diagnose and explain the condition. It helps in desensitization, teaching relaxation exercises, relaxation of abdominal, thigh muscles and vaginal muscles with self-exploration forms part of the treatment. So all this I have told. And another thing is I have seen many ladies with vaginismus, they have undergone the hymenectomy operation or the Fenton's operation. So the moment they say they were unable to have intercourse or do the penetration, so what they think, so this is easy, and they do on surgery, they say we will do the surgery, we'll make the place bigger so that you will be able to have. Whether I say whether the door is this big or this big, if you are closing it, the effect is same. So the surgery is not an indication. Vaginismus is not an indication for hymenectomy unless she has developmentally very small narrow intritus and also rigid hymen. So the use of surgical procedures in the absence of obvious abnormality is useless, unnecessary, and constitutes another form of assault. So the treatment can be successful within 3 to 4 sessions, although it usually requires 8 to 10 sessions, and women's motivation and cooperation determine the success. Because so many times what happens, the husband will be frustrated, loses interest, and there will be quarreling. He refuses to cooperate with the wife, and then that becomes very difficult to treat. And Kegel's exercise forms most important thing. And finished. Almost. So this is the botulinum which I was telling you. So it is multidimensional, multidisciplinary. Education is now that MCLA chair has come. So that 1,000 Kegel's exercises within a short period, it is sitting on the chair 20 minutes and switching it on, it can create the good pelvic floor exercises and relaxation of the muscle. So this also has come newly. So in conclusion, vaginismus as one of the common sexual dysfunction has a significant impact on impeccability of couples' relationships. Stratifying the severity of vaginismus has been found to be of value in helping to determine the best course of treatment. Attempt to find out that vaginismus is primary or secondary would be helpful in proper treatment of these patients. Recent studies demonstrate that pharmacologic therapies such as botulinum toxin have a significant benefit which could be useful in mild to severe cases. Combination of pharmacological treatment and physical treatment such as dilatation demonstrate to have a great result in comparison with previous single methods. There is still running research on treatment of vaginismus with higher rate of success without any chance of recurrence. Thank you very much for the patient here. Thank you.
We are breaking for lunch. Please be as quick as possible so that in about 45 minutes we can restart our post-lunch plenary session by Dr. Rajshekhar Brahmabat. And I request those who have registered yesterday but have not collected their delegate kits, please do collect it from the registration desk near hall number 2. Please collect before today evening.
Anukul, first slide. Title slide, beta. First, still. Okay. Good afternoon, friends. Loudly. Good afternoon, friends. That's good because it is post-lunch. I'm not worried about you people, but I'm worried about myself. If I go to sleep, then what will happen? So I have a very interesting topic, past, present, and future. Not only sexual treatment, but human sexuality. I would put it in a little broader umbrella. It's a very, very interesting topic. And I cleared my MBBS in 1970. First few years I was in a general practice and then started shifting from 1980 onwards for last 4 decades. So I have seen complete change in the part of the treatment, people's behavior, and the thing in which the human sexuality is as we see today. Now, first is the past. So let's start in the past. When we started, I'm saying we because my wife is here, otherwise she'll say, you are not thinking about me. We were classmates. So when we started practice, at that time, क्या हो रहा है? Up. Okay. I don't know, in sex, everything has to be up. So only thing was sex tonic, which was available at that time. And what were those sex tonic? Either they look like a male organ or a female organ. Either they were from the Vanaspati Janya, means from the plant origin. Khanij, that is mineral origin. And Prani Janya means from the animal. So these are the things over there. So sex tonic were there. As you know, ginseng, Spanish fly, you know it very well. Now, what were the drugs which were used? I'm not going to talk to you in detail because all of you are aware. Alcohol. And Shakespeare said it increases the desire but takes away the action. And today we know the effect on the liver and testosterone. Cocaine. Just now Amit Mutta talked a lot of things about there. Marijuana and Spanish fly. I'll request all of you to see the movie called Spanish Fly. They go, young children, they go and catch the Spanish fly. And there is a substance, cantheridine or something, and that increases, it irritates the urogenital tract. The main problem is the dose, therapeutic dose and the lethal dose, there is a small range. And it's the most dangerous, but once upon a time it was very popular. Lizard oil, horns of animal. Many rhinos were killed, tigers were killed because of their nails and other things. Ginseng, it is still surviving today. Shilajit, yesterday somebody said like that, कि तुम्हारा तो पत्थर के जैसा होना चाहिए, गाड़ दिया तो धड़ाक से आवाज आना चाहिए. Then amphetamine, LSD, hormones, testosterone, Musli Park. I'll come to Musli Park within a minute. Oyster. Now this looks like a female vagina and the pan. Now you'll be surprised in Chowpatty if you go. Once upon a time there was a pan which was known as a palang tod pan. By eating this betel nut and this pan, you get so much of strength that the complete bed will be broken. And I was told that it contains a lot of cocaine. And because of that, your perception changes. Vajikaran. What is the meaning of Vajikaran? Vaji means horse and Karan means act like that. So, घोड़े के जैसी अपार यौन शक्ति के लिए. And I had presented a paper at Alternative Medicine in Jaslok Hospital. And Vajikaran is a very beautiful concept. We may not agree today what it is. Ahar means food. Aushad, medicine, and Vihar. The most important part is the Vihar. With what company you are moving. If your company thinks that now it is time to retire, or it's a time that we should think about some Babas or Bhakta or something, you are in that mood. There are some people in Bombay I have seen, even at the age of 75, 80, that group regularly meets, and if you meet them, you will feel they are more than any younger person. So Ahar, Aushad and Vihar. And then this side is a Rasayanvati. Charak Samhita, if you go through, which was written ages back, and Shusrut Samhita, which is a surgery. Charak Samhita, there are 8 pillars, and out of them 2 pillars is one is a Vajikaran and one is a Rasayanvati. Now Rasayanvati, what we take like a nutritional thing today, anybody can take it. But Vajikaran only after the puberty until the menopause. So these were, it also, the concept were so beautifully devised at that time. Now Vasayana, 300 AD, he has written 2 complete chapters. And what do they teach? Beautification, how to beautify yourself. Also, they give the medicine which were prepared from the barks of the trees and some insect. Now, if it is touched on the penis, it becomes a very, very hard because it becomes swells up. And the other concept which I loved was because some of the leaves and some roots were taken, and if it is applied to yoni, that means inside of the vagina, she will feel like she is like a virgin, contracted. Her husband is coming after 6 months, 6 years. He'll find that she is like a virgin woman on the first night. I say this is a concept which they have given. It's a challenge to recent pharmaceutical company that you find it out. How can you do this? There are many nuskas, means the things which are given, you do this. These are not possible today. Don't try to do it. What is more important, the concept which they have given. And the last part in the Vajikaran, they say, interested and interesting partner. And Kama Sutra, Vasayan does not stop here. He says apadravya, what we see today, a dildo, not the vibrators. They were made up of wood, horns of animals, jasad, copper, silver, gold, and even ivory. So you can imagine that this topic was so detailed, taken up once upon a time when they were written. Because those kings, they had harem, more than 50, 30, women. So these things were required. Now coming back to this is a very important, I'm sure you may be in any part of India, at least something you will be using it. First is a methi. And Dr. Sanjay and Venkatraman will agree with me, nowadays if you find methi has been given a lot of importance, and nutritional drugs which are. My grandfather used to take every winter musli, this one, what you call the methi colored one, they were very bitter. And then chavanprash, and which was made up in an iron vessel, not like what we get today. Second was white musli. Even I have been given a white musli. In a Bombay, there is a place called Masjid, from wahan se white musli la ke usko powder banate the. And after powder, they used to mix some milk and some fruits. And exactly it will look thick like cement. And I don't know why they were given. Now, retrospectively, when I was searching, so I found there. Kaucha Park. Now you see Spark over there. It is Swami Prakashanand Ayurveda Research Center. And I was a, fellow over there, and we were doing a research in Ayurveda. Ayurveda is our science. Today on the name of that, somebody will try to do something wrong, but it is our heritage and it needs a scientific studies to be done. So Kaucha Park and Ashwagandha, these are the two things we found. And then I had left that as I entered into a sexual medicine, more details. Adatya. Today also, if you remember, there was a sorba of urad dal. It is considered to be very, very good. Vasana, during winter season, all dry fruits were brought and make a like a peda sort of a thing. And lastly, Chavanpras. So I'm sure if you go and if you scratch your head, your grandparent, you may be from any part of India, you must be taking this, you know. Now, Ayurveda, so when we started a practice, 2-3 companies like Himalaya, Charak, Jandu, these were the roaring, and particularly the one which you see over here, that Tentex Forte, silver color peel. Tons of them were sold to the Arabian countries, you know. They thought because the color, first of all, silver, and either the gold color or silver color will be there, but the thing which was there, it takes care of infertility, impotency, what they used to use, liver function, digestion, mental. I said, how one can act in all the places? But till today, they are available and they are there. Then the thing came out 30 plus and other things. So first change came was the Ayurveda, which came after the traditional things. Now today what we see over here, and I also do prescribe Nanoleo or Erectex or so many others are there. Again, they contain methi or kaucha or ashwagandha, which is being put there. And you supply to them, you give to them, it forms a base. And in some cases, people have said that they feel very good, but I do not have complete study with me that I can guarantee that you should start giving to everybody. Yohimbine, this was a wonderful drug. I still use it. Only one company in Bombay is making. It is available 2 milligram, not 5.4 milligram. So literally 3 tablets, 3 times a day you should give it. Now this is, they say it is same as the placebo, but what happens, it gives a turgidity to the penis. So there are people who have a lot of anxiety and they say their penis is shrinking. For them, it is good. Side effects are increased blood pressure, tachycardia. And how they found it, that in America, African population which were there, they were much stronger sexually than their white people part. And then they found that there was some, tree in Africa, its powder and bark were taken. Testosterone. Tons of testosterone myself have given. That time we thought that this is the only medicine because it is connected with the male hormone. So agar koi ne 100 milligram diya, hum tumko 250 milligram depot preparation kenge. And then later on, recently, I think Dr. Narayan Reddy and myself were there when Andriol was launched in Kuala Lumpur, oral testosterone undeconate. So you can use any form of testosterone if you feel, but before that, there should be a biochemical evidence. Early morning report should be there from a reliable laboratory, number one. Secondly, you should see that you don't give it to younger people. It affects the spermatogenesis. And lastly, elderly people, you should think about the prostate. So this is, I say, if it is judiciously used, it is a very good drug. Now, bupropion hydrochloride. Sanjay, can you see the gentleman over there who he is? He is Phil Donahue, the Oprah Winfrey's godfather. And in 1986, I was present in 2 live shows at New York TV. And it was a live show. And Helen Kaplan was there. And Crenshaw, who was a world president, and Helen Kaplan said that Valbertine is the really first sensible sexual stimulus. That time they thought it's going to change the world, but it didn't do that. And this was a Valbertine. Trazodone. Lot of my psychiatric friends, they use it. It's an antidepressant. Mechanism of action is not fully understood. Now, it is no FDA approved for erectile dysfunction. So it is off the shelf. Side effects are drowsiness, dry mouth, sedation, and priapism. Now, this is a very important part, priapism. I haven't come across anybody, but it has been reported in the literature that it causes a priapism. Now, we are entering into the past. We are living and entering into the present. The past is a stepping stone, not a milestone. So I would always say your history is a very important, and those who does not know the history, they don't know where their root belongs. So everybody should try to think about the history. So let's enter into the present. Now, 4 drugs which has changed the complete life of mankind. First was a penicillin, second was insulin, third was oral contraceptives, and fourth was our sildenafil citrate. And I would like to share over here that oral contraceptives were not easily available, or they were not allowed to be used in Japan. After the sildenafil, when it came, then the women came out on the road and they said, why we are not allowed to use oral contraceptives? So these are the 4 drugs which has changed. And particularly, I was chief investigator for one of the pharma company. 5 people, we have a multi-centric trial, double-blind, crossover, and with a placebo control. It was accidentally discovered. They were trying to find something for coronary artery dilators, and then they got it. Most important part, 2 things you must remember as far as the sildenafil citrate is concerned. It is not a sex tonic. And secondly, whether you use 50, 100, 200, if the optimum result which you have got, it will remain the same. It's not going to increase with the dose. And third part, unless you tell them to stimulate, now with most of the physicians, they forget, or psychiatrists, they forget. They write it down. And when it goes, they say, Doctor goli liya, kuch hua nahi. So morning ke time mein kuch thoda tightness laga. So this is the drug which has to be used. Now, credit goes to 3 gentlemen, Robert Furchgard, Luis Ignero, and Farid Murad. They were in 3 different parts of the USA. And what they found, that the signaling molecule nitric oxide, which is there, it causes a dilatation. And the main whole thing is endothelial, and endothelial, which is important. As you see on my suit, there is an inner lining. So inner lining of the vessels are very important, and anything, you would say it's an endothelial disease rather than anything else, today. And all of you know, Anukul, next slide, please. It's not going. So here, now the endothelium, what happens for the nitric oxide? L-arginine in presence of oxygen and L-citrulline. This is causing nitric oxide, and then the whole thing is known to all of you. Now, this is a very interesting thing about L-arginine. It is a precursor. So nowadays we find plenty of L-arginine drugs, sachets are available. I regularly use it. I start with the 1 sachet, and after 2 days or 3 days, I say take morning, evening. Every corner has got different types of thing. I cannot say that A is perfect or B is perfect, because during this lockdown, I had a patient all around India. So whatever is available to them, I'll say, you show me the photograph and we'll say agree. But this is one good drug, I would say, which is in our testing. Now, sildenafil citrate, oral, safe, convenient, broad spectrum. Previously, we used to break our head, whether it is vasculogenic, neurogenic, endocrine problem, psychogenic. No, you can give very safely. And it is first time FDA approved drug has come up. And I would say that and tadalafil in combination, you don't have to worry. These are 2 excellent. Now the newer drugs are coming up. But my teacher used to say, you must feel the drug. Use one drug, 3 months, 6 months. So you know side effect, what will happen when the effect will be there. So then you can go ahead and start with other one. And whenever a new drug comes, there is always pharmaceutical will come and say, this is the best drug. And after a while, another one come and that one is thrown out. So we should not be pharma driven. We should be very clear what we want to do in our life. And as far as the drugs are concerned, my teacher used to say, when a new practitioner starts his practice, he uses 10 drugs for one illness. And if he successfully ends his practice, he uses 1 drug for 10 illnesses. And that is what you should try to feel the drug. And once you give the drug, the problem another with the drug is I have finding that if you write it down, most of the people will Google it. And very next day say it is a dangerous and they will throw it away. So I don't know whether you should give it from your own place or you tell them that this drug is used for many other reasons, so don't worry about it. Now, sildenafil, vardenafil, tadalafil, udenafil, avenafil. Now, just now, our chairperson told me that we are also coming out with CSEPI. So that will be the next addition to the whole thing. Sildenafil, as I said, 25, 50, start with a 50 milligram, maximum once a day dose. Yesterday, somebody was talking about one of the cricketer, he died because he took a large number of dose of, Viagra. Now, window period 30 minutes. Most important is in case of a person who has got a retinal, pigmentosa, he should not be given. It causes an abnormal vision. And lastly, take care of an elderly patient. Now, when it came first, there were more than 137 or 140 people died, and they thought attributed to the Viagra or sildenafil citrate. They did a study, they would have died because of any other reason. It's a very, very safe drug. Give them a proper instruction and definitely good results, except in case of a diabetic, where we'll have to see what to do. Tadalafil, another excellent drug, I would say. Fortunately, we are available 2.5, 5 milligram, 10 milligram, 20 milligram. And if you remember at Nagpur, somebody presented a paper, 2.5 milligram for 6 months that doctor had given somebody, urologist. And it's a very good drug. Only thing, in couple of people, there is a lot of backache, pain and myalgia. So you tell them that if you get this, and some people have got very severe. So you tell them to take any painkiller or paracetamol of their choice, take a hot water bath and try once more, and otherwise you don't try to give them again and again. The care has to be taken in case of a younger person. It also acts on the PDE11 and that is affecting the spermatogenesis. What I do is I use both of them in combination. One side like a Kapil Dev like batsman is there who come third and sixer and four. And other side, Dravid like who manages. So tadalafil in a small dose, you give it for a long time and tell them on demand whenever you require. And don't tell them, say that while taking a bath, just take a soap and water and that to plain. I don't want you to have an erection. So you are giving a information and then they get an erection and then they come and tell you that we get an erection. So they have a full confidence what is happening. When you give any drugs at the night time, they feel this is for the sex. So these are the things one can use it. Apomorphine. I was told in between it was there and now it has come again. It is probably safe with the nitrates. And you can give it every 8 hours the dose, and it can be used sublingually. Side effect I have spoken. In case of sildenafil, 5% abnormal vision, tadalafil, backache, rhinitis and myalgia. Now, this is a very interesting that PD5 is contraindicated with any nitrates. Frequency, sildenafil once a day, vardenafil once, tadalafil once in 24 hours, while apomorphine every 8 hours. So thrice a day you can give them. This is a very interesting slide. Particularly, I wish that Muthu would have been there, Amit. Amyl nitrate, coppers, the people who are using, they do this. So even that can be dangerous in any form nitrates because it causes a irreversible hypotension and that's why very difficult. Now, a period of 24 hours of short-acting PDE5 and 48 hours for long-acting, meaning by, you have seen that today people are very much conscious about their health. They go morning walk, morning jogging. Somebody said, yeah, take this Viagra or take this tadalafil. He takes it. He has not told anybody. While doing some activity, he gets a severe chest pain. So I request all family physician, you tell them that before somebody ask them, have you taken any medication? And if they have taken sildenafil, next 24 hours, you have to put them on a supportive measure. And if they have taken tadalafil, next 48 hours, don't touch them. Leave them with supportive measures. Otherwise, you will create a serious problem. And last, vardenafil has an effect on acute interval. So it can cause a cardiac arrhythmia. So the drug which can cause, one should always remember. Now, depoxetine, lot of things have been said by Sanjay today in the morning. It's for the first time, SSRI, this is specially for it. Short acting, oral on demand, rapid acting. Dose 1 to 3 hours prior to intercourse. And intra-ejaculatory latency time, 3 to 4 times it increases. You can give 30 milligram or 60 milligram. Rapid elimination. Last 3 is very important. No drug-drug interaction. No SSRI withdrawal symptom, because otherwise you give SSRI for a long time, then there is a withdrawal symptom. And no sexual side effects, loss of libido or erectile dysfunction. And along with that, now we are lucky that we can use tramadol, and which can be a good combination, and local, some anesthetic agent, but which Madam Padmini said that the most important part is the sensation and you are cutting away. That was a very nice point I got it from your talk today. Brindless, who showed in front of a group of urologists in San Francisco, injected himself and showed that erection. I was rather first to come in 1986 to start the injection. Fortunately, I have never got except one case, not a single priapism. It's a very good drug, but after coming sildenafil, I have stopped giving it. But I know our 3 or 4 brothers, they are just using this, and it's a very good drug, particularly the sildenafil failure cases, those who have a diabetes, it's a good, and now it is mono, bi, tri, and all sorts of things are available. So this is, but before you take in the hand, you should know how to treat a priapism. What happened so many times, what happened in my case, a gentleman came and he said, kuch bhi nahi hota erection. So I gave him a papaverine in a larger dose, thinking, but people wants more from you. And that's why they don't give you a correct history. Muse, I have never used it. It is a pessary which is very famous in the France and other things, put into the urethra. It causes urethra irritation, infection, burning, and erection is not that good. So 250, 500, 750, and 1000 microgram, it is coming up. Vacuum device. Again, for Indian people, I have not found it very useful. But implant, there are 2 types of implant. An implant were first to come. People have used the bones of the animal as an implant, earlier days. And this one is inflatable, and other is just like a rod, which you put. That is much simpler, no mechanical problem, safe, infection chances are not there. And I would recommend all of you. Rupin Shah is one of the BC Roy awardee, very young person, dynamic. He had come earlier for a long period. He has devised this. Now, other implant can cause you 5 to 7 lakhs. This will be within 1.5 lakhs, and it has been used for last 25 years. So it is time-tested thing. Now, every case you must take down 5 minutes before you write your prescription. Tell them to change their lifestyle: alcohol, smoking, obesity, and stress. And unfortunately, including myself, many of you may not be using any one of those things. We are not following. And the sleep is the first thing. Whenever anybody comes to you, first question, apart from asking, don't go to the sexual question first. Ask, how is your sleep? How is your appetite? And then slowly, what I said, non-threatening question to go to the threatening. And sleep, if they are disturbed, either they've got anxiety, depression, or some sort of a problems over there. Again, all of you know, so I don't have to say, balanced diet, sleep, and yoga. Glossy magazine. What has happened in prison? Today you open any glossy magazine, and on front page there is one article. So female have become more alert about their own sexuality. And I had a girl who came all the way from a very conservative family in Lucknow to find her G-spot. Says, my husband is not able to find it. So these are the things which happens, and it's good thing. And today, in any party you see, we can joke about sex in spite of male and female, both are present. This is one of the change which has done. Sildenafil cited in today's era, that sex which was a taboo, which was hush-hush thing, now we talk openly, we joke about it. This is a good point about it. Now, in case of a diabetes mellitus, I am requesting all of you, if you don't do a blood sugar studies, I think it is a criminal on our part. First thing you must do is a study and do whatever you want. Now, 3 times it is higher erectile dysfunctions are there. And every 5th person sitting over here has got a diabetes, or probably is going to get a diabetes in the future. Depression. I think we are all living in a stress century, and during this lockdown, I think that was a major thing. And young people, adult and elderly people, or even female, anybody. And you must find it out whether primary the depression is because of the sexual dysfunction, or because depression was there and medicine were given and then person has got a sexual dysfunction. Prostatic, lot of things have been said. PD5 inhibitor, tadalafil 5 milligram per day gives a very good result post-operatively. And it can be given for a long period. So temporarily cavernous nerve damages which are there, each can be repaired. And this is a good drug. Now, cardiac condition. Surprisingly, yesterday I was talking to women, myself and wife, talking to one of the friend. And both of them, husband and wife, one has undergone 7 stents were put, another she has undergone a bypass surgery. So this has increased now. And you must give them a correct way. And so many times after bypass, they're still continuing, sorbitrate without reason. That should be stopped. And it should not be marathon race or anything. If they can walk on a plain ground for 20 minutes, within a 20 minutes without getting breathless, or 2 staircase, or 4-minute Bruce taste, I think they should be allowed to enjoy the sex. Now, what are the safe drugs? Antihypertensive, angiotensin receptor blockers are very safe. Antidepressant, trazodone, nefazodone, bupropion, and mirtazapine. And all recent antipsychotics are very, very safe. Yesterday is a history. Tomorrow is a mystery. Today is a gift. And that is why we call the present. Past, now, and future. So let's go to the future. And I'm predicting, like a Jyotish sitting with the parrot, that gene therapy, stem cell therapy, P-shot, that is plasma-rich plasma, platelet-rich plasma, low-intensity shockwave therapy, low-intensity pulse ultrasound. These are going to be a future things. 3 or 4 slides are there. So there are many therapeutic options and they are all in the pipeline today. What is working? Friend, we are trying to make a sex very mechanical. It's not a mechanical. It is not a plumbing job. It is not a what man does to the woman in a 5 minutes or 10 or 15 minutes in darkness. It is how they react with each other, how they respect each other. That's the most important part, and which is forgotten. So in a dirty picture ways, they say what sells is the entertainment, entertainment, and entertainment. I would give you a mantra. What works in sex is sensuality, sensuality, and sensuality. And I was in Japan 3 years back. There was 3.5 hours journey. So there was a mic. So they said, "Doctor, you are here and we would like to make the best use. Whatever questions are that they asked me." And in the end, while returning, I said, "I want to ask one question to all the women. Tell me, what do you expect from your husband? What do you want from your husband?" I thought somebody will say solitaire, diamond ring, other things, saris, nothing. Only one word came. We need respect, respect, and respect from husband. And I think if we learn today nothing from my talk, learn to give a respect not only to your partner, but any female which you come across. John Bancroft was here and he said, "We do not treat male and female. We are making organ oriented." No. Sexual dysfunction, we treat the relationship. And where is the relationship today? It's only a living relationship. Today, the thing has totally changed. And how do I treat? I feel like putting a board outside. I only treat Viagra failed cases. And I'm requesting all of you to learn sex therapy. Sex therapy, sunset focus. I have converted into Indian model co-therapist. No, here you cannot afford. So only solo. Their couple was required. Now here, so many times they don't want to tell their wife. So many times young people not unmarried, they're widower, or they are having relationship outside. So they may come alone. Institute or hotel they used to ask to stay. Except 2 or 3 cases who came from abroad and for a very short period, I had asked them to be home or hotel. But most of the time you can have from the home only. Break from the routine. No friends. Here the routine continues. Nobody knows it. Only one case, very interesting. Every city has got one god. So what happened? I used to give them they had a problem of infertility. So they came, it was the problem of erectile dysfunction and the unconsummation of marriage. When I gave them another day, Friday or something, they were both feeling, "Sorry, sir, anytime you give us Mangalwar de do." तो बोला भाई, बोला घर में कोई को मालूम नहीं हम सेक्स थेरेपी को जाते, हमको बोला है कि हम सिद्धि विनायक के मंदिर में जाके हर मंगलवार का 21 दिन पूजा करेंगे तो बच्चा हो जाएगा. So still these things are existing. Referral not possible. I tell you, it is not a, it's an elephant sex. You need a urologist, gynecologist, skin specialist, diabetologist, cardiologist. So referral is very easy today in my work. 2 weeks treatment. So here it goes on 10 to 15 session. Sometimes I am out, sometimes somebody, husband is out, sometimes there is a social function. So I have changed a sensate focus to exercise. Today also morning when our chief guest said about exercise, I was feeling very happy that my word is taken up, because today we are exercise time bound. No, it's a flexible 30 to 45 minutes. Family not involved, family can be involved, and unfortunately today family dynamics are creating so much of sex problem. Saas, Bahu, Jethani, Derani, between husband and wife, so many things are happening. And the joint, there are certain communities, I have found Marwadis and Muslim, maximum problems are their family. No pharmacotherapy. Today we have got so many things, every day new pharmacotherapy. Surrogate partner, never use it. It is medically, ethically and legally wrong. Nobody should use a surrogate partner, which Masters and Johnson has used it. Marital guidance not given here, marital guidance is given. And vacation lost, there are 2 weeks. Here, once they are successful, they can go for a real second honeymoon vacation. And last but not least, today our friend from Sangam there, yesterday he taught us last 2 slides. He was teaching us yoga. Every one of us should do it. I have seen people who have done yoga, on their face you will find a light. Those who have taken early dinner, light. Those who have taken salads and green vegetables, there's a light. I'm not following any one of them. If you don't see, I go and eat all junk food. But this is what is required, sir. If we do this relaxation, you don't have to use any anxiolytic. And unfortunately, many of our psychiatrist friends, sorry to say, if somebody sitting over here, they say wine low, you wear some undergarment which are very this thing, put a music and like a cabaret you do it. Sensate focus is not that. It's a sensuality. It's not the sexuality. And skills you have to learn. And I have been conducting many workshops. Whenever you want, I can come and do it free of charge for our CSEPI. And this is how we teach them how to go about it. It's a long session. Now this particular, Dr. Gadre is there? I don't think so. He's the one, my young friend, like Parag ke baad mein wo mila hai. Very dynamic person. He has presented one of the paper, and some of mine and his thing, we have joined. Local regional drugs are going to come up. Sex pacemaker will come. Artificial intelligence and sex, that will be used, in future. Sex robot, you are here and you are enjoying with your partner. Sex chat. Then augmented reality, like what we wear and as if you are there. Virtual sex. Sex toys, which have now come up in a big way. And sex in the space. These were all technology. And social aspect, I say, live-in relationships are increasing. Open marriages are increasing. Swapping rates are increasing. Sex parties are increasing. LGBT will have their own problems. Drugs to enhance ecstasy, and especially for orgasm and other things, will be available. Virginity parties lost, premarital sex has lost those ideas. And now they compare with their present partner. Sex compatibility matching. Infection due to sharing their toys. Sex change operation. Sex coach as a surrogate. And magazine on video on sex will increase. What I and CSEPI and all of us, we say there should be a sex education in the curriculum. Sexual medicine should be given a branch, and sex no longer should be considered a taboo. Friends, let us talk about sex. Let's be in the present. And there my grandfather's poem, I remember, is a एक अंधियारी रात के बाद में सुबह में नया सूरज उगता है. I don't want to end with the negative thoughts. There is going to be a very, very positive in our life. Future is going to be bright. We all will have to work holding hand with each other in a big way and march towards, and never try to treat an organ, mind, body and soul. Unless we do holistic approach, nothing will happen. Future is going to be bright. Thank you very much, friends.
Excellent presentation, very insight.
I had faster, and secondly, post lunch, I was very much worried. I was not worried about number of people, but I said, people will sleep. No, I'm thankful to all of you. You are a great audience. Please give a clap for yourself. Please come. Please come. So people know that every time I have a different one with me. Right. Next session, I invite the chairperson, Dr. Rahul Patil and Dr. Rasin Sawant. Please come onto the dais and conduct the session.
Good afternoon, everyone. I would like to take this opportunity to thank the organizers for having invited me for this. I hope I can do justice to this lecture after hearing such a wonderful lecture by Dr. Brahmbhatt. Can I have the first? We all know that diabetes mellitus is a highly prevalent disease. And I'm sure every one of us sees diabetic patients in our OPDs or outpatients daily. It is an increasingly prevalent problem And the prevalence in India is said that roughly 11.8% of our population is diabetic on treatment. That means 1 out of every 10 persons is suffering from diabetes mellitus. And that's why India today has been labeled as the diabetic capital of the world. Now, what is the problem with diabetes? It leads to disruption of normal sexual function, both in the males as well as in the females. It is primarily because of the end organ damage. There is a damage to the penis and the nerves and the blood vessels to the penis. And there has been well established that the association between diabetes and erectile dysfunction in the literature. Now, what is epidemiology? How common it is? Sexual dysfunction is a common problem, and it is all the more prevalent in people who are having diabetes mellitus. It is said that the presence of sexual dysfunction in type 1 diabetics has been associated with markedly lower quality of life. So obviously, sexual function is important. It enhances the quality of life in any individual. What are the risk factors for erectile dysfunction? We all know that smoking, heart disease, high blood pressure, high cholesterol. And today what we are talking is diabetes, which increases the incidence of sexual dysfunction. And this keeps on increasing as the age of the person also increases. Now, compared to a non-diabetic person, a diabetic person is exposed to 3 to 3.5 times more probability of having an erectile dysfunction than in those people who do not have diabetes. Now, what causes erectile dysfunction in patients with diabetes? Diabetes affects all the end organs which are responsible for the normal erection and normal function of the penis. So the blood vessels are affected, as you can see. Atherosclerosis gets hastened, the blood vessels get clogged, and since erection is a vascular phenomenon, that's because of increased blood flow into the penis during the act of erection. Anything which clogs the arteries will lead to decrease in the blood supply to the penis, and obviously the erection is going to be either poor or absent. Nerves also are going to get affected. So the nerves supplying the penis, both the sensation comes down, and the autonomic nervous system, which supplies and brings about the effect of the nerves onto the penis, also gets blunted. So the nerves gets affected, the arteries get affected, and obviously even the hormones secreted, there's a testosterone secretion in these patients also is decreased. So it is multifocal. Diabetes brings about change, a master change in the environment within the body, and this causes erectile dysfunction in these people. So like what I've already said, there's already evidence now that diabetics also have an increased risk of low serum testosterone. So one should always remember that whenever you're treating a diabetic, even if his serum testosterone levels are normal, give him replacements of testosterone along with other erectile drugs. Low levels of testosterone may lead to decline in sexual function. We know that desire is primarily because of testosterone, but directly or indirectly, testosterone leads to erectile dysfunction, decrease. Now, we had an excellent study where more than 2,500 patients who are attending a diabetic clinic were assessed by us. And what we saw is very important to know that 68% of the people who are attending diabetic clinics had erectile dysfunction, out of which 54% had moderate to severe erectile dysfunction. So it's very important that compared to a non-diabetic population, 60% in India do have erectile dysfunction. Over 1/2 of the people affected with diabetes had poor glycemic control. So when we evaluated them, we saw that these patients had poor glycemic control. There was testosterone deficiency, and they had evidence of peripheral vascular disease. It is also known that a longer duration of type 2 diabetes was noticed as a glaring non-modifiable risk factor in our study. So this we have published in the Diabetic and Metabolic Syndrome, and it clearly shows that the people who are having diabetes are at a very high risk of developing erectile dysfunction. Now coming to how do we treat? So most of these patients obviously do come to you, and nowadays we are seeing younger individuals with the diabetes who come down to OPD or outpatient with history of erectile dysfunction. Now, as you all know that earlier we used to do a battery of investigation in these patients, in patients with erectile dysfunction. We used to do venous studies, arterial studies, nerves, nerve conducting studies, and all those things. But today it has been given up because we all know that it is rather futile to do major investigation. What we need to know is, since the introduction of PDE5 inhibitors, whether he responds to this treatment or not is most important. So the most important group of drugs which have revolutionized the treatment of erectile dysfunction is PDE5 inhibitors, and the commonly used PDE5 inhibitors in India are, as of now, sildenafil, vardenafil, tadalafil, and avanafil. So these are the group of drugs which belong to this phosphodiesterase type 5 inhibitors, and they are the ones which are commonly used today in the treatment of erectile dysfunction. Now, how do these act? What is the role of these drugs? We all know that PDE5 inhibitors are dependent on the function of nitric oxide and cyclic GMP. So like what earlier Dr. Brahmat was saying, that without desire, without a physical stimulus, without any stimulus, tons of these drugs are not going to be of any use. Even if you give them tons of these drugs will have no effect. So the person has to be told that he needs some form of stimulation. The stimulation can be either visual stimulation, it can be physical stimulation, or any other way. If he's reading books to get a stimulation, then he can go ahead. So they need to be given the advice that these drugs will act if and only if there is a desire and there's stimulation. So what does the stimulation bring about? Whatever be the stimulation, be it visual or physical stimulation, it helps in the release of nitric oxide at the end terminals of the nerves. This nitric oxide brings about the conversion of GTB into cyclic AMP, and this cyclic AMP is the one which brings about the smooth muscle relaxation in the cavernous tissues. The smooth muscle relaxation allows the blood to go into the penis or in the cavernous bodies excessively, and this brings about turgidity and rigidity to the penis. So the penis rigidity is primarily dependent on a vascular phenomena that's increase in the blood flow into the penis. So this is how the natural erection occurs. And what is the role of PDE5 inhibitors? The cyclic GMP which is there is metabolized at the end of the nerves by various pathways, and PDE5 inhibitors delays this metabolism of cyclic GMP. So there's excess of cyclic GMP at the nerve endings, which gives about bringing in prolonged stimulation of smooth muscle relaxation and prolonged erection. So that's how I already told you that PDE5 block the inactivation of cyclic GMP, which leads to persistently elevated levels of cyclic GMP, and this brings about continued smooth muscle relaxation and brings about erection. Now studies have been all shown, we all know that sildenafil, vardenafil, and all these drugs have been effective. And what was seen is that this was one of the major studies which was done by Goldstein et al. And which is reported as late as 2006. It shows that the erectile function score was 19 out of a possible 25 after giving a 20 milligram dose of vardenafil. And 54% of the men who were taking this were able to complete intercourse with an overall responder rate of more than 72%. So majority of the people who are having erectile dysfunction. And if they are given PDE5 inhibitors, they do respond to this drug and they get good erections. Now, like what we have already heard, is that all these drugs are well tolerated, be it sildenafil, vardenafil are well tolerated. But of course, you need to take an opinion from the treating physician or a cardiologist if they are either severely hypertensive or they are on particular drugs which are affecting the heart. Like what we already know that nitroglycerins are the ones or nitrates are the ones. If the patient is actively taking them, then obviously you need to avoid these drugs. So we rather in our hospital, we do take an opinion from the physician, treating physician. If the patient is hypertensive or taking other drugs, we always take an opinion from them before we start any of these drugs. Now, how do we give these patients with diabetics? Do we give them as and when they require to get PDE5 inhibitors, or do you give them continuous? So the studies have all shown us that if a patient is put on low dose tadalafil continuously, daily he has to take, not as and when he requires it, but on a daily, it brings about dilatation of the penis and thus prevents the fibrosis which can occur. A Denmark study has shown that a higher dose of PDE5 is required in diabetics. Similarly, that's why whenever we start PDE5 inhibitors in diabetics, we start at a higher dose. Now, you know that sildenafil is available at 25 milligrams, but we always use a higher dose, maybe 50 milligrams. And if that is not working, then we go to the dose of 100 milligrams. Most of the patients who are diabetic today in our series are getting at least 100 milligrams of sildenafil. We do not advise them any extra because of course the side effects are more with the higher the dose of sildenafil. So always in our patients, what we try to do, they are diabetics, we put them on a low dose of tadalafil, and for good erection, we give them as and when required. They can take an add-on dose or as and when required. So if they are on 5 milligrams of tadalafil, then we always titrate the dosage. Then we ask the day he wants to have sex, another 5 milligrams he can take 2 to 3 hours before having sex. If that 5 milligram is not working, then we can upgrade it to up to 20 milligrams of tadalafil. Or if the patient is already on tadalafil, we can give them sildenafil 50 milligrams or 100 milligrams as and when required. So there is a titration. We need to titrate the dose for each patient. Each patient requires a different dose. So we need to titrate the dose correctly so that what is best suited for him, we should be able to advise. So we also, our own studies which were shown that we did a study where using placebo, 2.5 milligrams of tadalafil and 5 milligrams. And what we saw it was that 38% of the patients on placebo, 42% on 2.5 milligrams, all reported the ability to attain an erection sufficient for vaginal penetration in the correct doses, in the doses given. And we have been also using daily dosing of PDE5 as a therapy, which will not only help in treating erectile dysfunction, but it is also a means to halt or even reverse penile tissue damage that leads to erectile dysfunction. Today morning, I heard one of the speakers who said that there should be a process of the penis being getting tumescent or getting rigidity on and off, because that will help the penis to go on further. Now, treatment of erectile dysfunction, this also has been told. So in those patients who do not respond to your PDE5 inhibitors, then what next? Do they have any choice? Then of course, these are the so they do need some other forms. So commonly what we have so in those patients who do not get or who do not achieve adequate erection with the PDE5 inhibitors, then we may advise them to use a vacuum erection device. This vacuum erection device will potentiate the effect of the PDE5 inhibitors. So patients getting incomplete or inadequate erection, we can use them. So similarly, we can use one of these trimix or bimix, which can include either papaverine, phentolamine, or prostaglandin E5. to potentiate the action of PDE5 inhibitors. And if all this fail, obviously, then we could keep on, we need to go for the next step, and that is obviously the surgical step. Next slide. Processes, now like what was already suggested, was first in the treatment. Actually, it was started late in the 1950s, prosthetics came about. It's an excellent option for treating diabetic men who are refractory to the drugs which we are using, be it PDE5 inhibitors or intracavernous injections and other means. The highest satisfaction rates has been seen with prosthetics. Introduction of prostheses within the penis has given an excellent result. More than 95% of the people who have been having this surgery, having undergone this surgery, have got a satisfaction rate. Now, we have been using, like what earlier has been sold, that we have been using the sharp prostheses commonly. The cost of a sharp prosthesis ranges between anything between 30,000 to 60,000, being it either semi-rigid or the one which is flexible. So we can use those processes, or the ones which are available from America, from the AMS and other companies. But of course, they are a little more expensive. We have got, we have been using a combination of both of this. And what we see at the end of this is that that more than 80% of the men who underwent this surgery reported were very satisfied with the penile implantation. And similarly, little less, maybe about 75% of the women or the women partners also said that they were satisfied with the penile prosthetic surgery. So this is as far as possible. The only side effect of using a semi-rigid is that the penis is always in an erect stage, and that one has to use certain preventive measures so that this is not obvious when they are wearing especially a tight pant or they are putting in shirts. To better overcome this embarrasses, obviously we can use inflatable one prostheses. We have got a two-piece prostheses or a three-piece prostheses, but they are expensive for an Indian patient clients. A two-piece would cost somewhere like 4 to 5 lakh rupees, and a three-piece would cost 7 to 8 lakhs. That's what we call it, the Ferrari of prostheses. There are very few patients who, especially in my center, very few patients who choose this kind of processes, obviously because of the cost. Now, they give excellent means of erections. The erections can be achieved as and when the patient can desire, and immediately after having sex, they can deflate the processes, and which can make the penis come back to its normal size. So this is very helpful. It can conceal your erections correctly, and moreover, satisfaction rates are also very high. The patient partner satisfaction rates are also very high with using inflatable prostheses. Now, this is what is coming in new. I'm sure everybody should know this. This is what we call as a shockwave therapy to the penis. Now, how does shockwave therapy end? I'm sure everybody would have known what is a shockwave therapy for a stone. The stones are broken by energy, which is extra outside the body. So similarly, a smaller unit can be used. We are using such a unit which is there with the physiotherapy department. And this is the handheld shockwave therapy unit. And what we do is here, obviously, we can see that we place it on the penis and we give repeatedly these shocks ranging from 500 to 1,000, and they come in sessions. So we need to do it in sessions. So what does this cause? This causes minor bleedings within the penis, or they break the concretions, or they break the calcium deposits within the cavernosa and develop neovascularity. They help in developing neovascularity, and that's the reason why the erections keep on improving. We still have not gone and done a prosthetic evaluation in this, but obviously this is the one which is coming up, and along with the use of PDE5 inhibitors, they bring about a good response. And of course, one need not forget the lifestyle changes which need to be done in these patients. Patients should know that they are diabetic. They should get their diabetics well controlled. Their glycemic levels should be very good. The HbA1c, especially, one should follow it, that they should be within the normal range. They should, of course, reduce their weights, go for morning walks, and use of various yoga and other techniques is very important. So in conclusion, what I would like to suggest is that sexual dysfunction is common in patients who are diabetic. And in terms of managing, PDE5 inhibitors are the excellent group of drugs which we need to use in these patients. If these patients are not satisfied with PDE5 inhibitors, then obviously the only choice is use of processes. And by using a combination of all these things, I'm sure we can make the life of these people much more better. Thank you very much. Welcome.
Now I request the chairpersons to felicitate our esteemed speaker. Now I invite Dr. Mrs. Smita Brahmabhat to felicitate our previous chairpersons, Dr. Archana Deshpande and Dr. Ramani. Now I invite the next speaker. Now I invite Dr. Rajshekhar Brahmabhat to receive his memento.
And topic is generative medicine in sexual and fertility. Dr. Natesh Prabhu is the urologist and associate professor at Dhanashri Srinivasan Medical College and Hospital, and chief editor of Grade Plus. Is a concerned medical consultant at Androgen. Dr. Natesh Prabhu.
Thank you. So good afternoon, everyone. So the previous speaker told about shockwave therapies, and next even Vijay is going to talk about PRP. I'll be not covering about the evidences of PRP or stem cell therapy. I want the practitioners to know that how to do a PRP therapy, how to prepare a PRP, because there are many non-surgeons here, myself, and we don't indulge in giving any surgical procedures. So let me be very clear in that. So this is going to be my overview. I'll be telling about the basic history of regenerative medicine, what is stem cells. And when it comes to regenerative medicine, people tell only about stem cell therapy, but it is not that. We have multiple things beyond stem cell therapy. It is called as scaffolds. We have growth factors, and we have all the indicated. So I'll be giving some coverage over there. And then coming to the sexual areas where I'll be focusing mostly on male sexual dysfunction and infertility. Female sexual dysfunction, I don't do that. I don't even see patient, but I'll be giving you some kind of an idea what people do about it, because people here can go and propagate that. And we all should know what is the regulatory standpoint. Where do we from India stand in case of regenerative medicine therapies? So this is not a new thing. Even the mythology has told that the liver cells were being regenerative in nature. So we can see from the history over there where Prometheus has given us a clue from the history. And we have been regenerating tissues, skin, bone marrow tissues. So this regenerative medicine is not a new thing. That's why I want to emphasize, because when people say regenerative medicine is future or is experimental, of course, a few things are experimental, but it is not emerging. It is a current therapy which we have to adopt. Now, first, out of these three things, stem cells, growth factors, and scaffolds, I'll be covering what is a stem cell. Stem cells comprises of self-renewal property and differentiating property. This we can go back to stemness. Stemness is a property of any stem cell which gives a capability of the cell for self-renewal and differentiation. So there has to be a balance between a proliferation, quiescence, and regeneration. The cells, it will sense the micro environment. It will see what is wrong there. It will go and migrate over there. It will secrete the factors. That is where it can act upon. It is not like you give stem cells, people think it can go everywhere. No, where there is an a chemotaxis trigger, where there is an health requirement signal, it goes there. So under normal physiological conditions, control shifts in the balance of such signaling pathways. It induces differentiation. For example, if you want vascular regeneration, there is a hypoxic stimulus where in the heart or in the limb. That is where the cells migrate. It goes and secretes all the factors. That is where it is going to differentiate or to act over there. Okay, how to classify stem cells now? Basic three things. We can classify it based upon this differentiating capacity, site of extraction, and the cellular origin. We all know about totipotent, multipotent, unipotent. Just know about this because we can divide cells into basically into pluripotent and non-pluripotent. Pluripotent can always be embryonic stem cells in origin, which even research is banned in India. So don't do that. Forget about it. Let's talk about multipotent stem cells. We have mesenchymal stem cells. We have hematopoietic stem cells. That is where we're going to indulge in. Remaining things we can keep for experimental sake. How to classify stem cells based upon the tissue of origin? As I told you, one is embryonic, then it is a tissue derived. Under tissue derived, we have fetal stem cells, adult stem cells, and under adult we have MSCs, SVF, IPCs, which I believe are telling you in detail. Recently, which is of high concern in case of fertility field, where we have failed to regenerate the sperm cells or the ovarian cells, they have discovered very small embryonic-like stem cells which are floating in the circulations, which can be extracted, and this is very good in nature to regenerate the spermatogonial stem cells. Even in India, Dr. Deepa Bhartiya from Pune, she has done multiple works in that. And I believe if somebody wants to work on infertility with stem cells, this is going to be of sort of interest for you. So based off site of extraction, if the person is a dentist, he'll go for dental bulb stem cells. If the person is a orthopedician, he'll prefer a bone marrow stem cells. If he's a surgeon, he goes for adipocyte stem cells. If he's a non-surgeon, we have two options now. We can go for umbilical cord banking stem cells, or we can induce the mobilization of the bone marrow cells into the periphery. It is called as peripheral blood stem cells. We can give multiple growth factor stimulus. It stimulates the movement of the cells from the bone marrow into the periphery. So this is all what we do in the lab. From the we extract dental pulp stem cells from the patient's own tooth, and this is what surgeons do. They extract a small chunk of adipose tissues. They process it, and they extract something called as stromal vascular fraction, which is nothing but a concoction of multiple lineage of stem cells. And from this SVF, we can derive adipocyte or adipose derived stem cells. I'll tell you how it is done in later slides. And this is how you're going to extract from the bone marrow. We do a iliac crest puncture and we process it and we'll go for culture. Then it's a bone marrow stem cells. It comes into play. Now, how do you culture? It's called as a passaging. You do this adipocyte, you do this bone marrow, you extract from the teeth. Everything gives them a precursor cell or a progenitor cell. From there, we go for subculture. It's called as passaging. Maximal passage, you go for third, fourth, or fifth passage. Beyond that, the chance of error is more in the cells. So we prefer to keep at the stage of third or fifth passage. More and more passaging you do, more and more yield you will get. It doesn't mean you have to keep on passaging it, you have to stop it. So we can stop it at the fifth passage and we can give for the patients if you get any approval from the Stem Cell Ethics Committee of India. ICMR approved thing. And like this is where we play your research playing role, how to improve the your stem cells efficacy. That is your lab stem cell efficacy. You can alter the growth factors, give hypoxia, give electroporation, give biophotonics. Multiple methods are there which every lab has to standardize. So this is how a stem cell looks at day 2, day 7, day 14, and the final one, spin-like formations, and it has to be adherent to the flask. And always you know that umbilical cord is a good source of stem cells, the water and jelly, the umbilical vein, the umbilical cord itself. That is why many companies are toward this umbilical cord. It is a very kind of a gray area where people can preserve it, but they cannot use it. But no one knows how they are storing it and whether even anyone who can pay for it, they can procure it for research purposes. That is what I mean to say. Okay, sir. I don't have any other facilities now. It is all bewildering for me. I can't invite a surgeon. I can't convince anyone. And I'm very skeptical about infect because for these extraction, you need to have a class 1000 facility stem cell lab. That is called as CGMP lab. If you're not having that, then you should not venture into that. So how to do that? You purchase a closed system. It is not going to give you a stem cell. It is going to give you a minimally manipulated precursor cell. For example, you have a orthopedician friend. You have a surgeon as a friend. You invite him. You take a tissue, a chunk of either your iliac crest tissue, a patient iliac tissues, or adipocyte tissues. You put into the system. The system will give you an end product which you can directly give to the patient, and it is being accepted now. It's a very closed system. It is very, very pure. But the cost is more. The system itself will be coming around 25 lakhs to 35 lakhs, and the dispensable itself will be coming around 60 to 70,000 rupees. So all it's like it all depends upon how you're going to pitch for the patients about the therapy. So this is what we have here. Can you just play the video? This is that second one. My teacher, Dr. Ravi, he's doing the bone marrow aspiration, and this is the mission. Now, why people talk about mesenchymal stem cell? Because hematopoietic stem cell has to be matched with the patient's per se, but MSCs need not be matched because it is immunoprivileged. What does it mean? It doesn't have major histocompatibility complex. That means it can be given allogenically. That is what it means. So one person can give to another person. And it can be, again, as told you, it can be extracted from anywhere. How to characterize? How will you know that you have got the stem cells which you have got, which you need? So we have to see for the positive markers, we have to see for the negative markers, and this is done by the one is immunofluorescence staining, and we also have done the by scholars fluorescence activated cell sorting by using flow cytometer. Because why I'm telling this, people think just you take something out of that, and people claim it is stem cell therapy. It is not. It's a huge science behind that. And now stem cells itself has some very unique mechanism action. The first mechanism is called as homing. What is homing now? When there is a signal from the dying tissues, the cell migrate over that. After migration, it can act in 3 pathways. One is a transdifferentiation. The cells can go for plasticity. That is where one cell will change into other form. Then something called the paracrine effect. It goes there, it secretes all the growth factors which are required for the cell to survive, repair, or regenerate. Then comes cell fusion, which is called as organelle exchange. If there's a damaged mitochondria, the stem cells migrates there. It gives the new mitochondria so that the dying cells, it regenerates. Then comes to the, then we come to IPS. IPS is of purely experimental as of now, because even in Japan, where the Nobel laureate has got that, but there are a lot of, legal hurdles, because they told you can reprogram an adult cell, bring back to its precursor state, then you can turn back into the lineage of your choice. It's like a time machine, where just by adding these two extra factors, this person got a Nobel Prize. And even in Japan, they have stopped this research on this wet macular degeneration due to some kind of ethical issues, where they're able to keep a patch over there and able to regenerate the macular area. Lost vision was regained. Only 2% were been done. The research is halted. Now, let us come to things which we can use very commonly, less of regulatory hurdles. One is being the PRP, the second is being the conditioned media, and third is being the exosomes. Now, what is a PRP? PRP is nothing but a plasma which is enriched with growth factors which are released from the platelet granules, which are necessary for the tissue repair and regeneration. Very simple. You take a product, you concentrate a maximal amount of platelet in that, and you make the platelet to release the factors. It's called a supraphysiological release of the growth factors. So we have multiple PRPs now. We have PRP lysate, we have PRP releasate, we have unactivated PRP, we have a lyophilase PRP lysate. So there are multiple things. This is a basic thing which you have got know about it. How does it act? Know about this. Just imagine this is called as the alpha granule. This is where everything is taking place for the PRP. After activation, the alpha granules, it breaks open, it releases all those growth factors. And depending upon the site, we're going to modulate the amount of factors in the PRP. And because we are in the case of the field of vascular regeneration, that is for erectile dysfunction, for thin endometrium, we are focusing on VEGF. And VEGF is not called as only as VEGF, it is called as angioneurin, because blood vessel flow will stimulate nerve growth also. That is why it is called as angioneurin nowadays. Now, I'm going to skip it because this is a basic platelet dynamics which can prevent the activation. And how to activate it? It is, we can add a calcium chloride. But I'll tell you that. Okay, how to prepare the PRP now? You take a 30 ml of blood. We have multiple spins. We have 1,200 spins, 2,000 spins, hard spin, soft spin. Then you prepare a PRP. Then you have to remove the white layer in there. This is the one. As simple as that. Very simple. Anyone can do in the clinic. There are multiple centrifuges available nowadays. It is called as PRP centrifuge, where you don't have to worry about the spinning speed. The cost is more. You buy the centrifuge, you take the patient's blood, you put in there, you spin, PRP is ready for you. But now the question is, how much activation has been done? This is what is the main key here. What we do in our lab, in the called as freeze thawing method, which we have found out has higher efficacy of number of factors in the this plasma. People give thrombin, people give calcium chloride, people give butterpaste. It all depends upon the surgeon's or the physician's preference. PRP kit is available. You buy it from the market. They sell you for 16,000 rupees MRP. They give you a cost of 3,000 rupees, but there is no proven proof of efficacy. There is no standardized thing because the amount of factors in this kit is always variable. So these are all the multiple mechanisms. As I told you, main thing, we have to standardize the PRP therapy. That is what is the main thing. I'm going to skip this now. Coming to the conditioned medium. Legally, stem cell therapy is very experimental. Now, how to take the effect from the cells? You put the stem cells in the media, you make it to grow, you make it release all the factors, you wash off the cells, you take the media. It is called as a conditioned media. You can give for the patients after a multiple processing. Now, you have to be very, very specific. I want exosomes. Exosomes are the functional thing which is going to give a lot of functional things to the cells. Then again, you process those conditioned media, you extract the exosomes. Many labs, they are into exosome therapy, but I doubt they're actually into that because as of now, science evolved to make it a conditioned media to be more simple. And exosome therapy is a little bit more amount of, I can say, processing is required for that. And this is how they take adipocytes, they culture into adipocytes stem cells, and they prepare the adipocyte conditioned medium. As simple as that, any surgeon can do that. And this is what is our current research now. We are trying to standardize it. And this is, we have been doing PRP for maybe 2 to 3 years. And initially we tried with 2 base injections, and now we go for 6-point injections. Can you just play this video? Can you mute the audio, please?
You need an anesthesia for this?
Yeah, it's an sedation. People do want sedation,
Anesthesia is compulsory.
ವೇಸ್ಟ್ ಮಾಡದೆ ತಗೋತಾ ಇದ್ದೀರಲ್ಲ ವೇಸ್ಟ್ ಮಾಡದೆ ತಗೋತಾ ಇದ್ದೀರಲ್ಲ
that can be vasovagal shot. I think sir will tell next time. Next part, he is going to share his experiences. But we don't prefer that because why the anesthesia? When patient is staying, we pay for safety also. That is what we do. It's a pure daycare procedure, especially until 10:30 a.m. We disturb by 5:30 p.m. That is very. I know that. See, for fine. I think next stage, sir will tell. Sir, I'm going to reserve it for your talk. Any good surgeon will definitely not tell you. What we have been trying to say, but then we have evolved. Then we thought this is next one. Next stage. So we do 6-point injection now. So we do near the corona, the bit of the penis, and the base of the penis. Can you cue it faster? That is what we call as lyophilized lysate, where we quantify the growth factors in that. So we tell it is about 600 milligram of PRP powder. So we don't know. Again, we constitute that indication for again PRP. So the physiological PRP. So that is where we are able to get efficacy with single injection. Faster because faster. Fine. So then comes your BMC machine. You can buy that. You can also, for diabetic patients who are not responding to PDE5 inhibitors, those era of implants or ICI, we no more recommend now, because there is a chance we can give them these kind of therapies. Now, why not implants when ICI? Because those two doesn't reverse the underlying cause. Those two doesn't give a natural erection. But these things give a possibility of natural erection. And we always combine this with low intensity shock wave therapy, because shock wave therapy is also a regenerative medicine therapy, because it is going to stimulate the release of inherent stem cells, and it is going to increase the arterial compliance. So it is going to be a pure combination therapy of that. This is a BMC on the penis. This is on the testis, where we give for NOA, that is non-aspirated spermia, and only for patients who have had a history of OA, that is called as oligoacidic spermia, but not with fresh NOA. And minimal testicular size should be more than 5 cc, because more than less than if you go, and we'll be having a lot of hyalinization, so we don't prefer that. So it is not for all cases of like male infertility. Yeah, the whole thing was done by Dr. Vasan, my teacher. So he has seen and he has found out that less than 4 cc it is not effective, more than 4 cc it is effective. 4 cc of testis. See, that is what it is not about. Our aim is not about expecting a natural pregnancy. We'll tell them this, you have to go for only ICSI or IVF. ICSI first of all. And with NOA, we'll tell them, you please plan for micro-TCA. Micro-TCA with ICSI. If at all you're improving more than that, it is fine. Else no. No fake promise of natural pregnancy, nothing like that. Absolutely not. So for thin endometrium, we give ultrasound guided into the uterine cavity. All reports are there. It is not a new therapy. Like you can give PRP, you can give endometrial stem cells. So you can go and search for that. For endometrial regeneration, everything is on the net. I'm going to tell about that. And this is where I have been. So this is my teacher, Dr. Ravi here. So we and like me and him, we have gone to Anadya, Gujarat. Dr. Akansha is there. Dr. Anayana Patel is there. And under her patient who was having very thin, I think like it is not Asherman syndrome. It is completely white endometrium. And they've given bone marrow cells into the spiral arteries of the uterus under a CT, under a cath lab thing. And the patient got pregnant. The baby was born. So we are not in an era of future. It is all happening now. Only thing we have to adapt to that. Even for PO, as called as poor ovarian reserve, where there is less amount of ovarian follicles, it's been tried. And the procedure is go via a laparoscopic approach, not via a transvaginal. And again, we have multiple evidence for that. And this is for female sexual dysfunction, where there is a clitoral insufficiency and where there is a dyspareunia or dry vagina, or so usually a multiple points which they give. And people ask what is about O shot and P shot. It is nothing but PRP therapy. It has been branded by the US. So don't go for the O shot therapy, P shot, nothing like that. It is simple PRP therapy which you do. If you put this O shot or P shot tag, you're going to have this liability of giving amount of the patient's amount you earn to the inventor of that O shot. So don't go into that. Waste of money. So now, where do you stand? Everything is clear. Stem cell therapy is only for hematopoietic stem cell transplant, but until now, now we can give for CLI2 due to Burgess disease. Stempeutics from a company in Bangalore, they are given that, and even Reliance is into the game now. And this is, we have my teacher, Dr. Ravi, again here, Dr. Pawan Gupta, Vice President of Stempeutics, and I'm standing here, my team here, and they have given stem cell therapy, mesenchymal stem cell therapy for a chronic limb ischemia. And multiple indications which you can see online. So how do we do? We have to integrate with the biotechnologist. We have to liaise between a surgeon and in a research lab. That is where we'll be able to succeed as a sexologist or a non-surgical andrologist. A department of like a DBT is giving a lot of funds. Nobody is tapping in a proper way. So money is there. Please make use of that. Regional medicine is a cellular pharmacology. It is present or future. Now, what is cellular pharmacology? Any drug can be a substitution or a symptomatic therapy. Only cellular pharmacology can regenerate and reverse the disease process. So my credits to my mentors, Dr. Shankar Narayan, who's no more now, and Dr. Ravi and Dr. P. Ramachandran, and of course, Dr. Vasan. Thank you.
I call upon the chairpersons to felicitate Dr. Natesh Prabhu. Dr. Vijay to felicitate our chairpersons for the session, Dr. Raj Sawant and Dr. Rahul Patil. Sir, इधर से Now I invite the next chairpersons, Dr. Pratap Patil and Dr. Lieutenant Colonel V.V. Kantait. Please grace the podium, the stage. We have two sections. I will tell you. Now I would request the chairpersons to invite the next speaker we have. Surgical management of erectile dysfunction. Surgical management.
Now I invite the next speaker, Dr. Vijay Deshpande, for surgical management of erectile dysfunction.
We are at the last stage. The surgical specialist is coming. It means that PDE5 inhibitors failed, and subsequently intracavernosus injection failed, and now he is with the promise, and with the last answer he is here. We must hear to him.
Good evening to all of you, all my friends, and really I congratulate the organizing committee, Dr. Shirish Malde, all President Secretary for such a beautiful conference. Now, today we are going for surgical management of erectile dysfunction. Most important thing I want to tell over here, most notorious and complex organ in our body is penis. Penis is a sensing organ and brain is a sensor behind that. So if anybody refers to me to do the implant for this, I never ever go for that. Next slide. Especially when patient comes to us with ED, always remember that we have to go step by step and never ever do any surgical procedure unless and until patient tells you and he is ready to undergo the procedure. That is very, very important. Now, there are different modalities we have seen. So whole day we are seeing about this medical, this oral vacuum devices, PRP, vascular repairs, penile implants, so many things. Now, since 1970, these types of implants are done and these are contained within the body. Now, what are the different types of penile implants? Rigid implants, semi-rigid implants, 3-piece inflatable, 2-piece inflatable, 1-piece malleable. Depending on the patient's IQ, we have to judge when all line of treatments are failed, which are the indications. Some cases, here some descriptive part I am finishing over here. See, congenital anomalies. Only implant is not the line of therapy. There are some congenital anomalies where web penis, sometimes
Please don't talk.
Peyronie's plaque.
People at the back, please don't talk.
Again, some post-traumatic causes. In pathological, we have some type of Peyronie's plaques or any type of bend in the penises, vascular causes and organic causes. Now, what are the indications in say sexual dysfunctions? We have tried all the options. Failure of medical line of therapy, contraindication for any therapy, vascular causes, post-traumatic and diabetes. These are the basic investigations for the fitness. It has to be done on the spinal anesthesia. Now, rather than describing the procedure in theoretical manner, here I am going to discuss 2 to 3 cases which we came across and how we have taken the decision. For that, you have to do a periotic catheterization, then penoscrotal incision, carpal dissection, carpalotomy, dilatation, semi-rigid implants are measured, and then you have to insert it. Post-operative care, catheter has to be removed on second day, not to sit on hard surface for 1 month, no sexual contact for 1 month, visit as per requirement, and if any infection or injury, they have to visit. So these are few complications like postoperative severe pain, erosion, glans or shaft fusion, infection, swelling, oversize. Now, surgical part has to be seen how few different cases come to you, and in such a cases, how you have to go. This is a special case in childhood. the dog has came and when child was sleeping, the total penis and along with testes, both are avulsed. At that time, 20 years back, you can say, he was taken to government hospital and there some resident has did the closure. And after that, when you can go for
एक फोटो के वीडियो घ्यायची फोटो के वीडियो घेतला असा एक व्हिडिओ फोटो घ्यायचा
by advising him. So you can see over here.
आमच्यापासून चालू करा सर सर्जन आणि ठीक आहे तिकडनं येत असंच ठीक आहे बंद करा आता
his grandmother in between
आमच्यापासून चालू करा सर सर्जन आणि ठीक आहे तिकडनं येत असंच ठीक आहे
taken made a life of by any type of some part of because this was his subject. Right? After pulling, we are getting some
रेकॉर्डिंग होते मध्ये रेकॉर्डिंग बोलू नका आता काही
Now see,
yeah.
one by one, thereby what at the time of childhood
ट्रांसपोर्ट ले लो सर असो सर ले लो जूम और दिखाओ करें ना सर छोड़ कड़स Yeah. तू काही हात लावू नको थांबी देत लागते Yeah. बरी केले पूर्ण It's like a whole complete penis is buried inside. So, okay. So now, अभी इसका एक वाजू सर ये थोड़ा आप उधर जाओ थोड़ा सा हाँ ऐसा दोनों ऐसा ऐसा हाँ ये टाइप फुल पेनिस में पूरे दो बस बस होगा ताकि मला इधर हाँ हाँ बस sufficient
now see the picture over here
थांब हे दाखव हा पार्ट हाँ त्याला इंडिकेट कर ना त्या क्वाड्रीच्या टिपनी न दाखवता फोर्सेपली लिफ्ट करून दाखवते सस्पेन्शन. ओके. थांब थांब लाईट बस. मग काय आता स्टील फोटो द्यायचे.
That much length was not possible. So we have put in a graph around the brain.
हे दाखव काय कशात भिजवले ते
लिक्विड पॅराफिन आणि पिटॅडिन.
So again, next case, very interesting case I will say over here. 22-year male across railway accident, got a pelvic fracture, stricture urethra, treated outside by end-to-end arthroplasty. Again, no sexual function. In such a complicated cases, it is difficult to go for the implant. All have refused that. With proper explanation, proper counseling, we have undergone the penile implant procedure. Next. Next. Yeah, we can see over here, I'm showing you routine penile. Next one. Next. Go for first. Second set first. Yeah, next. Next to that. Second set first slide. Next. No. You have to go for this file 2, first slide. Yes, the penile implant procedure by what was adrenaline normal line, 5 cc of adrenaline.
सीजर टाकून कट मार. एक सारखं कंटिन्युअस पण बरोबर किती कॅच करून कट मार.
सक्शन चालू कर.
नाही गरज नाही. तेवढं केलं थोडं बस. मग थोडं खाली पण कट किती कॅच करून कट मार. हात कट तुझा. आता एक डायल द्यायचं मला.
या माणसाचं
कॉस्मेटिक लॅबरेटरी मध्ये येतील का तुम्ही. सीजन बाकी नाही आहे ना. सपोर्ट देतो पट्टी कटर लागते पट्टी आणि 15 नंबरची बेली
23 नंबरची ब्लेड
मोठं बल्की लागते
काढावं लागेल
काढून सगळं काढलं
23 नंबरची ब्लेड
रिंग बनव असं हे हळूहळू काढायचं तसं बांगडीचं थोडं देऊन पण अजिबात दोन सपोर्ट कर हळूहळू एकदम हळूहळू राईट ते दिसू द्यायचं आता आडू पकड ना जरा त्याला शूटिंग करतोय तो तर दिसू द्या ते जॉईंट पण दिसू दे त्याला राईट शेवटी माणसाचं ते हे बांगडीच काढायची पेशंट जातो थोडी मोठी लगेच बरं वाटतं असं तसं किती आलं 6 का एसी फुल केला ना एसी मला घामायला शार्प कट पाहिजे 14.5 डिग्री जाईल नाही ना ठीक आहे आता कॅप लावून दाखवतो शार्प कट पाहिजे असं बॅगला आणि बरं कुसव म्हणजे असं पै पण कुसव म्हणजे बरोबर त्या साईडला बाहेर येतं असा अँगल दे ना असं म्हणजे ते सरळ जातं 90 डिग्री मध्ये तसं 90 डिग्री नाही आपण थ्रू अँड थ्रू बाहेर निघतो ना थ्रू अँड थ्रू बाहेर निघून गाठ बांधायची इकडे म्हणून तिकडून लांब कर घेतला म्हणजे ते याच्या बाहेर निघायला नको
आलं लक्षात आता पुढच्या ह्याला करताना आपण मी त्याची
खाली हात खाली घेतो ठीक आहे आता असंच वर लागून ठेवतो ना मला खाली घ्यायचे डायलेट आहे 10 डायलेट मग तुझ्या विजयमध्ये ते एक असं ते काढून टाकायला असं स्टेप होतं टाकलं असं टाकलं करा ते दाखव त्याचा एक फोटो काढ जवळ झालं का रेडी शूटिंग रेडी का दिसू दे ना मला ते दाखव ना ते दाखव आणि इट विल गिव्ह द कॉम्प्रेशन हिअर शूटिंग चला क्लोज करून टाका येतं ते आता बोला ना छोटे हॅलो उंगली से जास्त लॅटरल किंवा रचाकडून नको ते टच करून म्हणजे आपलं स्पीड चांगलं राहील जास्त लॅटरल नको माझं खाली कॉम्प्रेशन देणंच महत्वाचं आहे खाली करायचं
सीझर न उघडू का आता
प्रॉब्लेम मारेल तो जाऊन ते एरिया आपण दिली का आपण
युरोत्र इकडे आहे ना
लांब माझ्या हातात युरोत्र
स्ट्रेट आहे सगळं
हे नाही माझ्यावर घे आता
ते चालू बस झालं आता. हो, हो.
मग घेऊया शूटिंग घेतोय ना येतोय का जे इकडं हात आणखी काय तुझी हो त्याला शूटिंग करू हात क्रॉस करू शूटिंग करू द्यायचं मला हां शूट करू द्यायचं मला हां
त्याला पकडू नको असं मध्ये हुक कर हुक कर रे व्हिडिओ असं खालून त्याला डॅमेज कशाला करतोय
नाही ना हां घेतोय 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 रोज माफ कर त्याला तर व्यवस्थित दिसू दे हे घे मला हळूहळू घ्या तर माफ कर टेस्टी असं आहे हां तिथून हां तर स्टोरी काय फायदा असं घेतं माझं हां मध्ये टाकून काढतो हां स्ट्रेट आहे सगळं
satisfaction end part conclusion. Relation between doctor and patient is very important. I have written so many books for the purpose of education. I might and more than 5 years. And unless faith is created by the different that by the doctor. As a combination therapy. Now, what is doctor? Why when careful faculty can made when like I think and it was damn good with without good input. So most physical fatigue. So from that.
Namaste. Good evening to one and all. So after watching two very advanced Dr. Natesh and Dr. Vijay sir's talk, I go back to my Ayurveda regarding sexual health. Usually, when come to the layman, usually when we think about layman, they think Ayurveda and sex like this only. Ayurveda, we are getting in the tents or in the lodge or in any footbath like that. These kind of people, they are making huge money. Only their consultation charge is around 3,000 to 6,000. So we cannot charge in the retail time also like that of they are taking consultation charge very huge. When you come to the medicine it will start 15,000 to 40,000. They are taking the only for the medicine, and they have good listening skills. They diagnosed as per the patient thought. They get the weakness of the patient and get a money. So this is the digitalization effect. Now online also, we are getting so many Ayurvedic medicine by quacks. They are also making money offer. If we send any SMS or phone call, they repeatedly concern about your problem, and they are offering 3 months treatment with money offer also. But this is the image I got almost weekly 1 or 2 patients. They are bringing these kind of medicine to my clinic. If they're not cured, again, if they call to the market, they told that you should take minimum 1 year for this treatment. So that is not a Ayurveda. Actually, Ayurveda is mainly using the principles of nature and maintain a health by individuals' mind, body, and the spirit in the equilibrium nature. Usually basic of Ayurveda, we find out only by three doshas, Vata, Pitta, Kapha. These doshas are all common in every individual, but one dosha should be dominant, and that will work on for any function, not only general health, including sexual health also. We should find out the which type of three doshas, body type, personality, sensitivity. According to that, we should diagnose. Saptadhatus. There are 7 bodily tissues which will help for nourishment, growth, and structure. What we call Rasa, Rakta, Mamsa, Meda, Majja, Shukra. So here in Ayurveda, there is a unique treatment is there. When we have a sexual, means the individual have a sexual dysfunction, we should treat from the basic, not only the reproductive organ. There are 8 branches in the Ayurveda. Almost 2005 years back only, they recognized sexual health and reproductive health. Kaya Chikitsa, Shalya Tantra, Kaumarabatya, Shalakya, Bhuta, Agada, Rasayana, and lastly Vajikarna. They give importance to the sexual and reproductive medicine. So Vajikarna, what we call the sexology, it will work for both reproductive and sexual health. So there are 4 stages of human life: Brahmacharya, Grihastha, Vanaprastha, and Sannyasa. According to that, there are 3 pillars: Ahara, Nidra, and Brahmacharya. So here, when should human being continue the sexual activity? Not before 18 years. It should be in the 26 to 40 years and 41 to 50 years. The highest is 18 to 25 years. In Vajikarna, they highlighted that excited or aroused woman is the good sexual medicine. When you come to the copulation, yesterday our Kohari sir highlighted Sambhog. Sambhog means 2 words, Sambhog and Blog. So here Sambhog means maintaining balance and Bhog means pleasure. Means in Ayurveda, intercourse is maintaining equilibrium along with sexual gratification. So it highlighted mind-body relationship in the sex. Means Sankalpa, what we call desire, originates in the mind. After that, Chesta or foreplay, what we call a foreplay, it should continue the desire. Stimulation of erotic organs resulting in Nishkasana, means ejaculation. Means 5 senses along with both the partners is very, very important in the sexual act. The treatment should be for both mind and body. And in Ayurveda, they told about which are the season good for the sexual activity, especially in the decrease of sexual activity should be in the spring season, summer season, and monsoon season. Here it should be once in 3 days. And when you come to the increase in sexual activity, it should be in the autumn or winter season, because that time the human health should be very normal. When you come to the best time for sex, that 10 p.m. 6 p.m. to 10 a.m., 10 p.m. and morning hours and evening hours are very important. This is scientifically proved that in the morning hours, the testosterone is good, and the evening hours, the female partner is very supportive because of estrogen stimulation. So the best practice of sex should be, it should avoid the sex during the periods and during the eclipse. And we should, what they told that oral and anal sex is abstain, and we cannot have the sex after food, and bath before sex is very important for hygienic purpose, and cleaning of genital organ is good. And along with that, after sex, both should get a milk, 1 cup of milk. Regarding reproductive health, The healthy food and good sleep is very important for reproductive health. And they told very long back that back position is the good for reproduction, means fertility, and purity of both the partner is very important for reproduction aspect. So sex during the pregnancy is 3 months in the pregnancy should be abstained, and during the means after childbirth, if it is normal, after 40 days, if it is surgical, maybe after 3 months. The sex benefit, they highlighted that the memory, the cognitive thought should be improved, means physical and mental health should improve, and sleep, very good sleep they are getting regarding aging and improving bonding and relationship. And they highlighted that sex addiction is very dangerous. The impact of globalization, what we are doing now, the family and culture is totally changed. The marriage values are also changed. Now live-in relationship is very common in small towns also. So there are so many STDs are arising. Along with that, food habits, very commonly we are getting outside food, especially in the midnight also we are seeing Zomato and Swiggy people in the road. So our food pattern is totally changed. Sleeping pattern also changed. Husband working in the night shift and wife working in the day shift. So these kind of change getting after the globalization. So because of that, we are getting so many sexual problem cases in the clinic because of stress, family, work or finance, lack of physical activity, less sleep because of workaholic. Most of them are not going for the sleep, and they are planning only in the weekends for the sex, but they engaged with any function or any commitment. So lack of sex is because of also arising sex problems and different working hours, food habits, and lack of sex education. And there are so many rise in the metabolic problems. So what we do in the consultation is we are taking history, because in the Ayurveda, they told about how to take a history regarding any general and sexual health problems, along with physical examination. Along with that, we give a sex education and counseling, and we planning the treatment according to their dominant doshas, and we do a panchakarma treatment, that is shodhana, purification of a toxic body. We should do according to them, because nowadays the patients have no time, because olden days we are doing more than 7 days or 14 days of panchakarma. Now we tailored the panchakarma according to the dosha and prescribing medicine along with lifestyle modification. So these are the recent research papers regarding the sexual health in Ayurveda. That is Vajikarna, treatment of sexual dysfunction based on Indian concepts. A review on classical Vajikarna formulation of Shweta Musli, development and evolution of aprodesic potential of a classical Ayurvedic formulation, that is Kamadev Bruta, and utility of Vajikarna in general health, Vrishya and Vajikarna exploring ancient science of aprodesic, a brief view on Ayurvedic herbs possessing aprodesic potential. And there is single drug study also on sexual dysfunction, that is effect of ashwagandha rasayana, and clinical evaluation of the spermatogenic activity in the ashwagandha. That is phytopharmacological regarding tribulus terrestris, and regarding tribulus terrestris in the oligozoospermia, chloropatum in the sexual behavior and sperm count, and memory gland of the genital organ in the asparagus racemosus, that is shatavari. The conclusion is, when we think about the Ayurveda and sex, we usually think that the tent or lodge, the local people, but that is not Ayurveda, because in Ayurveda, there are 8 branches, including the Vajikarna, means sexual and reproductive health. In that, we should highlighting the which season we should have the sex, benefit of the sex, mind and body relationship regarding the sex, and regarding lifestyle changes with medicines for rejuvenation. And in Ayurveda, the reforming is the research is very fast now compared to the previous because of our central government of support. This is a very recent slide. The WHO organization is agreed for the Gujarat research study regarding the traditional medicine, including Ayurveda with Ayush department. Thank you for patience of listening. Thank you, sir.
भाषण देता नाही काढ हा तू साईड लाव हा आपण ते आपल्या याच्यावर टाकू भरपूर सारे कर हा बरं झालं चल चला 1 2 3 4 5 what most important thing so आलं अरे वा
माझा हे नकोच सॉरी स्टिल ऑन स्विच ऑफ